It's unmuted.
Yeah, Good morning, everyone. Thank you, firstly, so much for coming, taking the time of your schedules to be here. My name is Mip Sakon. I'm an ICU physician here at Vancouver General Hospital and do some research on the side. I'll be moderating for today, so bear with me. I've been known to go off script, ask our nursing staff. Before we begin, there's a few people I'd like to introduce. First and foremost, before we start the day, I'd like to acknowledge that we are here on the unceded lands of the Musqueam, Squamish, and Tsleil-Waututh Nations. This is truly a not only provincial but national event. We have over 150 people online across Canada and various different groups. And I know many of you have traveled from places that are not the Lower Mainland. So I would encourage everyone to think of those lands where you hail from, which are on which we live, work, and play. To welcome the event, it's my esteemed honor and privilege to introduce Elder Dennis Joseph from the Squamish Nation.
Sam, thank you. In hot stomo, in hot squallowing, Quichtal, Quishaman, Hamalchasin, Okameo, Nishka, Welsh, Irish, Scootmish. Quichtal is my ancestral name. I am Nishka, Welsh, and Irish. Yes, indeed. In a few moments, I'll share a welcoming blessing song, not only for this day, but for tomorrow as well. You know, I've been in this room a few times, and wow, what a lively group. Hot squallowing means that place in your heart where you're somewhere between happy and sad, and it's indescribable in our language, hot squallowing. But I've come to understand you deal with transplants. And I want to, before I share the blessing, share a very personal story. I grew up with an uncle who was only 3 years older than me. Respective dad's mom and my uncle, their mother had the youngest when she was 42. And we grew up as brothers, especially playing sports together, lacrosse. In our language, it's called skechwa. And when I was very young, I had a heart-to-heart talk with him. I said to him, you know, when I get older, I'll call you uncle when I have kids or you have kids. It's then I can call you uncle. Until then, I'm going to call you brother. Is that okay? And he nodded. I was like 17. Well, lo and behold, we get to sit at the leadership table for many, many years at Squamish. And he ended up here after serving 36 years at the table, waiting for a heart transplant. A very delicate time, I'm sure, for community, for his family, for his wife. And we would sit out in these halls, waiting our turn, waiting for a match. Lo and behold, he got one, and he survived for about 20 years. And he went on to serve all of those years at Squamish. At the end of his life, a very quick teaching from our elders, they said, always be ready. Well, I get a phone call from Uncle's daughter. They were here with the whole family, the wife. And she called me Uncle, because she's much younger than me. That is the way. She said, Uncle, can you come here? Dad's not listening to us. We said everything that we can say to him, and he said everything that he can to us. Can you come tell him it's okay to go? So I came and spoke to him as good as I can in our language to give him permission to go. It was one of the most difficult things I've ever had to do to a brother, an uncle. Within hours, he had left us. You see, we trained together spiritually with other elders. As much as we did the political work, we sought balance with our elders from all over Coast Salish territory. And for me, they don't necessarily have to be Coast Salish. If you have something good in your heart to share with humanity, I'll listen and pass it on as best I can. And ha stomo, and ha and squalo and siam and siai, hoichoch and muskrium, slewatooth and skoltmish, Krishtal Krishaman, Kumkumalai, Sequalia Slolum. Sequalia is the vehicle for this song. I want to bless those that'll be here. I'm grateful and thankful to each and every one of you for answering the call to be here, you lively bunch you are. And those that'll be here the next few hours. Oh, it might get loud. Sam Stomo, fellow human beings, a blessing for each and every one of you, especially those online and hot. Take care, enjoy the day.
Thank you very much, Elder Dennis. It's my pleasure now to introduce Dr. Maureen O'Donnell. Dr. O'Donnell is the Executive Vice President for Clinical Policy, Provincial Clinical Policy, Partnerships, and Provincial Programs at PHSA. And her purview encompasses many things, but including the health improvement networks, as well as laboratory services and medical imaging.
Thank you, and BC Transplant. So good morning, everyone, and welcome. I'd like to thank you, Elder Dennis, for the very personal words as well as the beautiful opening. And I acknowledge that I'm here today on the unceded ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh, and I'm very grateful to have the opportunity to be here on their land. I just wanted to say a few words of welcome. And, I think the story that you shared, Elder Dennis, is one that can resonate with many of us. And I, too, have had a personal experience with transplant, although somewhat more distant, in that one of my friend's husbands needed a lung transplant. And I saw how challenging it was for their family to wait while he was waiting to find the right set of lungs. And there were a few false starts where they thought they had lungs that would match and they weren't the right size. But eventually he got that lung transplant, and it's a couple years now. And I literally saw within a couple weeks the life come back into him and the visible relief within their family. And, we say those words, that transplant is the gift of life, and we say them so easily. But when you experience it personally, or as we all do professionally, it really is a true gift. And so the work that you're going to be talking about today and this intersection between critical care and transplant is super important, not just to us all professionally, but also, for those people that need transplants. You may know that there are currently at the end of the fiscal year, so March 31st, there were 653 people here in BC, and of course many more across the country who are waiting right now for a transplant. And so while our transplant numbers are, they're stable, they aren't growing enough for us to actually provide transplants to all the people who actually need them. And so our work, excellent. We have more work to do. And, I think one of the important things to talk about with respect to donation is that, we saw a big change. Remember back before COVID, where we would, go into the ICBC and do our driver's license, and we'd get asked whether or not we wanted to be an organ donor. Well, with COVID, that all changed. And so we saw people signing up to be organ donors dropping off. And yet here in BC, we actually saw the numbers of organ donation, the organ donors remain relatively stable. And why is that? Well, it's because of this intersection between critical care and transplant. So it's the work that goes on to support families and individuals when they're critically ill that has helped to maintain those numbers. And so I think that all of you in this room, looking at this intersection around transplant and critical care, I hope you realize how grateful we are and all of those families are who receive a transplant for the work you do, because it is you and people like you that are helping to maintain those numbers of transplants. So I just say thank you for that. Now I wanted to also, say thank you to the sponsors for today's conference or meeting, because your work and support is also part of why we are able to come together. Now, I wanted to just say a couple words about intersections. So the first one is about these intersections between teams. And, we don't have to look too far to know about the uncertainty in the world and the uncertainty even in just the cost of healthcare and how are we going to continue to maintain our healthcare system. But when we start really thinking about how we have these teams of expertise, the teams who work in the critical care units and the teams who work in transplant. And when we think about how we can bring them together to really even further accelerate our work together, that's one of the things that I see as being the beauty of a meeting like today. So congratulations on being here and looking at that intersection. The second important intersection is around our clinical practice and evidence. And when I looked at the the program for today and tomorrow, I could see science written all over it. But I could also see, how it's practical, how you can use it in your day-to-day work. And so I think, thinking about science, but then really thinking hard and long about how we implement it in a really practical way, I hope that, and it looks like this will be a time for you to be able to do that. And then I think the third intersection that I think is maybe, in my view, the most important, although they're all important, is the intersection between science and humanity. And, I think especially when we're talking about transplant and donation, organ donation, this ability to be excellent clinicians and to be driven by science and to be furthering our knowledge and to be looking for how we continue to develop new research, even beyond what you're going to hear about today. That's super important, obviously. But thinking about the humanity side of it and what that means for the patient, for the family, and even for us as healthcare providers, where we sometimes have a very difficult role to play, I think that intersection is very important. And it looks to me, based on what I see in the program, that those will all be intersections that you're going to be exploring during this meeting. So I'd just like to say thank you for all you do. You are already making a huge difference in the lives of people. And thank you for being here to further explore this work together. Also just want to quickly acknowledge the nurses who might be in the room. It's Nurses Week, and thank you to all the nurses. And for those of you who are not nurses, but like me, work with nurses, make sure you reach out and thank them. And I think the sort of theme is about nurses' power to transform. And it seems really fitting that as you launch in this meeting today, that's the theme, because I think it does, obviously, you provide tremendous care and caring to patients, but being at meetings like this is about the ability to transform together with the rest of the team what we do. So thank you for all you do. And so with that, I wish you an excellent meeting, and I wish I could be here for the whole thing because I know I would learn a lot, but I look forward to hearing about the parts I won't be here for, and thank you again.
All right. So we're gonna jump into the program. Just before we do that, I'm gonna build off of Dr. O'Donnell's comments. I think a lot of people talk about, I've heard the term mentioned, breaking down silos, but I really do believe that this sort of event does that. And there are specifically 3 entities that have sort of coalesced together to make an event like this possible. The first is BC Transplant. I mentioned earlier, I go off script. I was provided talking points by Sean Keenan, but I'm not going to use them. BC Transplant, as you know, is a foundational organization for our province. I haven't even practiced this, by the way. There are numerous organ donation specialists in the audience, and the work that you do facilitates the gift of life from one human to another. And that's, I think, a really unique thing about donation and transplantation. Maureen talked about the humanity and the humanity of that gift from one human to another to enhance quality and prolong longevity is something that is very unique in this field of medicine. And so to the organ donation specialists, to Sean and Eric, and all of the BC Transplant staff, I think I know even innumerable patients and families who are indebted to your services. And I think the other thing that you do very well is you manage to marry intensivists or medical specialties with surgeons. Hey, Persanto. But these sort of collaborations are difficult, and you manage to do it flawlessly. So to all the staff of BC Transplant and the leadership, thank you. The second entity that has come together for this is Critical Care BC, which is a health improvement network, or an HIN, embedded within PHSA. Now, I think we can all agree that COVID was not so awesome, but one of the things that did come out of that was Critical Care BC. and under the leadership of Hussein Kanji, Ben Ridout, and all the staff, Critical Care BC, from my perspective, and I know from many, has really helped tremendously in the provision of critical care services in British Columbia, especially to underserved settings. And so Critical Care BC and all the staff there who've managed to pull a lot of this together, very grateful for yourselves as well. And then the last entity is a smaller one, but I think important, and that is a research cluster at UBC called Cerebri. This is a conglomeration of people from basic science all the way to clinical trialists who are all focused on one pathophysiologic problem, which is brain ischemia, or lack of blood flow to the brain, a problem that has evaded our best attempts in medicine so far. And it's that entity that has also provided a substantial amount of sponsorship for this day, and has now delved into death and donation science research. So with that said, I'm going to get into the program. What you will notice, there are 4 sessions, 2 mornings, obviously, and 2 afternoons. We have tried to develop the sessions to follow the gift of life. Today, this morning, you will hear about death determination, the science of death, the dying process, how we arrive at the decisions that withdrawal of life-sustaining therapies is the next step. In the afternoon, we'll go to the second stage, which is donation, and traversing the concept of dying to then giving the gift of life. Tomorrow morning, it'll be the third stage, which is post-mortem interventions or graft optimization, and specifically getting into a concept called normothermic regional perfusion. And finally, the 4th session tomorrow afternoon will be focused on transplantation and recipients. So the aim is to logically follow that path of how organ donation happens and then follow it into the recipients. You will also notice in the program and the aspects, one of the aspects I must say I'm most interested for are the integration of patients and their families into the program, because they are the end users of the work that we do, and I think provide, in many cases, the most impactful perspectives. So I'm going to start with the first speaker. He needs no introduction, but Professor Shemi, or Sam, as he goes by, is a professor at the University of McGill, or McGill University, I should say. He's a pediatric intensivist, an ECMO specialist. He's a recipient of the Order of Canada. More than that, he is probably one of the, if not the, authority on death determination science internationally. And we're so fortunate to have you come, talk, and to learn from you.
Can I do it from here? Yeah, of course. Thanks. Well, thank you very much. Good morning, everybody. Thank you, MIP, and the entire team for putting this together. It really is. When I reviewed the agenda for the meeting, I thought, wow, this is an original meeting. We haven't seen this in Canada before. So thank you. I'm just going to jump into it. MIP talked about this. I'm just going to go through the objectives for the meeting. To understand the common physiological pathways to death, the rationale for a single brain-based definition and determination of death, the impact of life-sustaining treatment interventions to prevent death, and the impact of organ-preserving interventions that complicate the peri- and post-mortem phase of care. I am sensitive to the fact that there are family members who have lost loved ones in this room, and many of us have lost loved ones in this room, and it's hard to talk about death and try to insert some humor without appearing to be insensitive. And so I'm going to share with you something that our hospital chaplain gave to me about 20 years ago. He showed me this picture, and it's a group of chimpanzees who are looking quite serious, and the question is, what are they looking at and how are they feeling? And they're looking at the death of their matriarch in Cameroon in a protection facility for chimpanzees in Cameroon. And it's quite striking how the emotion on their faces and the interaction between everybody is there. And it just reminds us and me that death is inevitable, but we can never overstate how impactful, distressing, traumatic, and psychologically damaging it can be for all of us. So while I will try to insert some humor into this talk, it's really always about reverence for life. I learned this in discussions with John Doster, who is for decades in this country was a leading bioethicist in donation and transplantation. I've been privileged through Canadian Blood Services and Health Canada to lead or co-lead 24 leading practices that have engaged critical care to take ownership of deceased donation in our country over the last 22 years. There are a number of people in this room who are part of these initiatives, and I thank you all for the collaboration and the commitment and the research development that came about this. Of those 24 leading practices, 40% are directly related to defining and determining death. And why is that? Well, over 80% of all organ transplants are donors after death, and that means we have to make sure that we retain and grow the trust and integrity of our partners and of our patients and families, that there is a medical, ethical, and legal framework for defining and then determining death and avoiding diagnostic error at all costs. My apologies if some people have seen parts of this talk before. Sometimes I think it's like Led Zeppelin playing Stairway to Heaven again, so why does Shemi and Barbie, what do they have in common? Well, we've both had this. I'm not hearing audio. It's up there when we started. Oh, back. Led Zeppelin has a better road crew.
If only I was paid like Led Zeppelin.
Led Zeppelin also had better hair.
Yeah. This is true.
Do you want to call? I don't know why the audio's not going through.
I think it's better just.
Sorry, I have a lot of audio.
I don't think we can. I don't think we can.
No. Are you sure?
Yeah, because he just embedded the video into this.
By any chance?
What do you mean?
Because I think we might have to just open it up in Google Chrome because there's no.
It's embedded in the top.
Yeah, it's embedded in the
Yeah,
top.
because for some reason there's no volume coming from it.
Well, it's got to be an audio output issue, no?
Yeah, I feel like it should. Let me call
I mean, the fact that the video's playing, it means, right?
Yeah, because it is weird, like the fact that the video is playing. I think he went into sound settings and saw that everything is.
There's a lady who's sure all that glitters is gold.
Are we okay to skip it for now and come back to it?
No. These are the audio settings over here. Yeah. Yeah. Okay.
All the volumes listed like videos from Google Phones, and all those videos worked. Like everyone can do it. Sorry about that.
That's okay.
But yeah, if by chance you have the original links like the PowerPoint, then you can get those then, right? Because they're just YouTube links, right?
No.
Oh, they're not?
Embedded videos.
Oh, that's right. Okay, that makes sense. It's because they're embedded.
You can go. Where are you doing that? Yeah, confirm. Oh, okay. Or
If you want to
is the
switch
next
it,
speaker? A playback? Yeah, playback
see if
audio.
they know.
Okay, my apologies about that. We're going to try to sort this out in the meantime. I think Sam actually has quite a few talks or quite a few videos to provide. So perhaps what we'll do is we'll switch it up a little bit. Sam, we'll sort this out for you. I'm sorry.
No, don't worry about it.
I'm really sorry.
Do you want me to? Can I HDMI it from my laptop?
I don't even know what that means. What we'll do, but yeah, let's give it a go.
Yes, it does. It does. So there is volume coming through.
So you can plug it here.
Yeah, great.
So it should be on the other end, I'm thinking.
Okay.
Yeah, so we look at the screen here.
Okay, I'll double check with Sybil. They want to know if I can back on the sound and everything. Just want to make sure that this is.
Is there any audio settings for that?
He's saying that we have to reset the computer.
But if the thing is just for that video,
Yeah,
I don't think, would that even do anything because we were playing other things?
I'm not sure. Yeah, that's what I was saying. Because all the other volume is still coming through. Like,
Can he come or? I don't think that's the one, Nehemiah.
he didn't show up. Yeah. Hey, so we're trying to pull up the video through his own computer,
Sort it out for the rest of the talks, yeah?
I mean, we don't know if there's anyone else.
but we have
Okay, so
That's fine.
we're trying to load his video up
it is kind of
on
It is very
on the room
embedded videos. They're
through his own PC.
It's never
But
been
now
a
the
problem
input-
before.
Yeah, but now
It's never been a problem.
I think it's best if they come here and see if they can.
Do you want to bring the second speaker up?
Yeah, I'll
Yeah, no?
yeah, why don't we, okay, why don't you guys look at it?
Yeah, can you
Put my talk down and you I'll just give my talk.
All right. Yeah. All right.
It's the MIPS Symposium. He said he has embedded videos as well.
There's a lot of background noise. Everybody that's on.
You guys
As far as I can tell, looking at my computer.
Go through.
Okay. Okay. So part of this is being really flexible, right? So we're going to switch it up a little bit while we get this sorted out with. I think it was in a Mac issue, perhaps, right?
Certainly seems small.
Yeah. If we learn from our counterpart down south, the first lesson I've taken is always blame someone else. It's too soon, right? Yeah, it's too soon. Okay. So what we're going to do while we get that sorted out, I'm going to. I was supposed to talk after lunch or after the break, but instead I'm going to go right now, and it's still death related, but instead we're going to focus on the physiology of death and the science of death and death research, and that is to draw physiologic insights into the human dying process. I have no conflicts. The brain, arguably the most important organ in the body. Right, Percento?
Totally.
Yeah. He's a liver transplant surgeon. But also the least understood and the most complex. And it's the connection between the heart and brain, which is what governs life, the two most vital of all the vital organs. And if I may say, perhaps the most important mechanism in the body is that when the most important organ is lacking the most important molecule, which is oxygen. That process is termed ischemia. Michael was a patient, is a patient. He was 26 at the time, February 2023, in our intensive care unit. He was admitted. Michael had cardiac arrest. And his MRI eventually revealed the dreaded words hypoxic ischemic brain injury. Low oxygen, low blood flow, brain injury. It was catastrophic. And his parents, David and Laura, made the excruciating decision to proceed with palliative care. It was their wish he be an organ donor. It did not work out. And a comment from his parents rang really true that day when we were leaving the hospital. His father, David, said, "Well, we've looked into his eyes, he is gone." The eye represents the only physical manifestation for which we can look directly into the human brain. In the back of the retina, those same nerve endings from cones and rods traverse the optic nerve through the midbrain and then eventually into the occipital cortex. It is the only way that we can assess involuntarily what is occurring throughout almost the entire central nervous system. And perhaps what his father was getting at by looking into his eye was the concept of death. This seminal work, led by Sam and many others in the room, redefined death in Canada as a uniform definition, and that is death is defined as a permanent cessation of brain function. And that can occur from the cessation of blood circulation to the brain. Clinically, though, those of you who do DCD will say, well, that's not how we determine death. We watch the arterial line. We watch the pulse pressure at the radial artery. And when that goes less than 5, then we secondarily deduce what we are seeing in the radial artery, in the wrist, is what is occurring simultaneously in the brain. Well, in 1783, Alexander Monro of the Monro-Kelly Doctrine stated that the quantity of blood that circulates in the brain is greater than most organs of the same weight. Thus, one of our arms will be found to weigh more than our brain and cerebellum, yet the area of the two vertebrals and two internal carotid arteries joined together are much larger than the area of the proper subclavian. What he was saying at that point, 250 years ago or so, was that the brain has an out of proportion amount of blood flow for its mass. And we intuitively know that now. But what that also means is that the circulatory bed of the brain is different. The regulation of the blood flow is different than what we see extracranially, or at least we think. But here we are 250 years later, equating the two. And the critical assumption in our current definition is what is happening in the brain is simultaneously happening in the radial artery. Is that in fact the case? Well, going back to what Michael's dad said, we looked into his eyes, he is gone. Shortly after he said that, this was a picture of the monitor, and that was his blood pressure. So his parents had deduced that their son had passed, even while his blood pressure was 75/36 and his heart rate was 66. Now, Michael wasn't able to donate his organs, but his parents very graciously donated his brain. And this is kind of what we found. This is not the exact slides, but very similar. On the A panel is an electron micrograph of what a blood vessel in the brain looks like at the capillary level. In the center of that, right here, that's the capillary. And on the side there is something called a glial cell, which is like a helper cell that helps keep the vessels open. On the B panel is kind of what Michael's brain looked like after his cardiac arrest. All the white stuff there is edema. The capillary is really small, so it was constricted. So there's a lot of resistance to flow. Meaning that if you think about a garden and a hose, and you make a kink in the hose, eventually that garden's going to die. And with all this resistance to flow, perhaps his blood flow to his brain did cease before his heart stopped. Now, when we're thinking of studying the brain, I would also say it's the most complex, but it's the most vulnerable. And how do we ethically assess the brain, the most important organ in the body, when it's undergoing the most important process, that of cerebral ischemia in the body? We cannot ethically make ourselves ischemic. So there's got to be a different way. Well, let's switch to the dying process. What does the dying process represent? The dying process is ubiquitous. It is going to happen to everyone. It has happened to everyone. But if we shift our thinking a little bit and think of it as a stimulus, think of it scientifically as a challenge to the brain. It is a progressive loss of oxygen and blood flow to the most important piece of tissue in the body. That also provides an opportunity to study the response. Which brought us to this study that we've been doing in collaboration with many of the speakers you'll hear from. The first aim was, well, geez, could we even study the dying process in a human? Is that possible? Now, people like Sunny Dinani and Sam Shemi have already shown that you can. They published that work in 2021 in the New England Journal. But perhaps in a brain-centric way, can we study this? Two, if we can we draw insights from the timing and the relationships between the heart and the brain to inform how they function with one another? There's not a blood test. Those of you who work at the bedside, there's not a blood test for the brain. There's no brain troponin. While studying this process, could we identify perhaps a protein that we could use to risk stratify patients and serve as a brain panel? We do liver enzymes, we do creatinine. Why don't we have a blood test for the brain? Part of the reason is we cannot experimentally make the brain so ischemic. And finally, we sought to do autopsies, and I'll get into that. This is what I call the watered down version. But what we do in this work is we monitor the perfusion or the blood flow in the front of the brain, so middle cerebral artery that supplies most of the front of the brain, and then the posterior cerebral artery that supplies the brain stem. We also place a catheter retrograde that goes up into the jugular and it sits just distal to the major venous exits out of the brain. So we measure oxygen saturation there. And then for the heart, everyone has an arterial line. They all have telemetry, these patients. But we also place a Swan-Ganz catheter that goes and sits in the pulmonary artery to read venous oxygen saturation in the heart. So venous oxygen saturation in the brain and the heart, so we can compare within an individual. And then we care for the patients as we normally do. We collect blood samples, though, before, during, and after to try to identify the brain troponin, and then the patients undergo a brain and heart autopsy. And I'll show you why we do that. Many of you have seen a Swan-Ganz catheter. So in the middle screen there, there's the tip sitting right sort of probably in the proximal pulmonary artery. There's an arterial catheter in the radial artery. And so we're measuring mechanical and electrical heart function. And then for the brain, this is this robotic ultrasound that we use so that we don't actually need to stay at the bedside. It goes zzz, 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 zzz. And yeah, I'll repeat that. Zzz, zzz, zzz. And it monitors blood flow live. And then that catheter that goes up and sits at the base of the brain monitoring oxygen as it exits the brain. This is what the bedside looks like. There's a lot of stuff. Mind you, these are patients who are passing away, and their families are at the bedside. We've had 20 people at the bedside in some cases. We've had patients of various different religious denominations. And so it seems like a lot at the bedside. And so the first question, as I said, was, well, can we actually even do this? Like, is this just ridiculous? Well, this is the feasibility. On the y-axis are the individual patients in the first 32, and now we're sort of mid-40s right now. And on the top there are the various different metrics that we collect. Orange are the data points per patient. I'm going to point some things out. So ECG in everyone, arterial line in everyone. Well, everyone has that. The middle and the posterior cerebral artery blood flow velocity with the ultrasound, almost in everyone. The SJVO2 is that catheter that gets placed at the base of the brain. And then I'll draw your attention to the blood tests and then the autopsies that are collected in almost every single patient. The PAC is a pulmonary artery catheter, or the Swan-Ganz. You'll notice there's the first 10 we didn't collect because we didn't actually have consent for it and ethics for it, but subsequently we do. So yes, studying this process in humans who are passing away is feasible. Secondly, timing. Now if we take T0 to mean the time at which extubation occurred, on the y-axis are the individual patients stratified by their diseases. HIBI stands for hypoxic ischemic brain injury after cardiac arrest. There's some patients with sepsis, traumatic brain injury. All this is to show there's a lot of heterogeneity. Some patients pass away really quickly, some patients take a long time. And there's no pattern per disease. Secondly, this is when it gets really interesting. If we take T0 to mean the time at which the blood flow velocity stopped, in dark blue is the time from then to when the arterial pulse pressure went less than 5, which is our current definition. In light blue is the time from then to when electrical asystole occurred. Again, lots of heterogeneity, no real pattern, but in every case, it seems to stop before. The brain stops perfusion before the systemic circulation does. To really drive this home, now we're undertaking perhaps a bit more of a provocative study where I think transcranial Doppler is awesome, but it is still non-invasive and it still has limitations. So now we place catheters in the brain in patients that read blood flow, oxygen, metabolism. And there's a CT scan showing the catheters on both sides of the brain. And this is kind of what one of the cases looks like with all that monitoring. And then we undertake a CT perfusion scan to map the blood flow before and an MRI. And this is when it gets super interesting. This is the pulse pressure right here in green. This is the brain oxygenation with, again, a gold standard catheter that is reading oxygen in the brain live. And it gives out there on the right, and it gives out there in the left hemisphere. And what we see, though, is pulse pressure actually give out way later, 10, 12 minutes later. That's 10, 12 minutes of warm ischemia time that makes the difference, as Prasanto knows, between a liver or no liver and the quality of the graft. We also collect metabolism. So this is when we're measuring, we dialyze the brain. and we assess for different molecules. On the top here is glucose. So glucose starts off pretty high in the brain, and then as one gets close, it peters off and goes to zero. But there's also a rush of an excitatory neurotransmitter called glutamate. So the brain releases this massive flush of this excitatory chemical. Thinking of patients who've stated, oh, they see the light or the light flashes before their eyes. This is the transcranial Doppler. In this case, the velocity right here gave out right around the same time, actually, as the invasive monitoring. And then it started searching for a signal, so it started going zzz, 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 zzz. So that's what all that noise is. And then the last thing is we place electrodes in the brain as well. So EEG electrodes inside the brain to measure electrical activity. So pairing perfusion with activity. Some interesting things that we've seen, if we map out the opportunity in AIM-2 of pairing blood flow to oxygen, or blood flow in the brain to function of mean arterial pressure, we see linear relationships, but we also see a lot of between patient heterogeneity. So what does this mean? This could mean the patients with a steep relationship are those sepsis patients you see in the emergency department who are comatose at a blood pressure of 80 on 50. Versus the ones with the shallow relationship, that CHF patient that you see 80 on 50 who's totally awake and talking with you. So a lot of between patient heterogeneity. The other thing I want to highlight is the slope of that relationship is slightly less steep for the PCA, the posterior cerebral artery, than the middle cerebral artery. What that means is that perhaps the brainstem is a bit more resistant to ischemia, which is important for death determination science because we need whole brain. Now you might ask, well, why are you putting in catheters in the brain, and why are you putting, or the catheters that go sit up at in the venous part of the brain and then the Swan-Ganz? Experimentally, this is the perfect control. It's the same patient, just a different organ bed. And so what should happen as the patient starts to pass and the patients start to become hypotensive is the body should say, oh, I need more oxygen. I'm going to extract more oxygen out of the blood system. What we see, though, is that happens in the pulmonary artery. It goes up, but in the brain, it doesn't. Perhaps indicating one of the reasons why the brain may be so much more vulnerable than the other organs. If a patient has a cardiac arrest, like in Michael's case, his body came back, but his brain did not. And that question has always been, well, why is the brain so vulnerable? Could it be that there is something different about oxygen exchange kinetics in the brain versus other organs? Possible. The other thing that we have seen is the physiology of agonal breathing. I know there's some critical care paramedics in the room. And nursing staff, all of you, I'm sure, have seen towards the end of life the physical appearance of agonal breathing. What does that mean in the human body? In yellow is the pulmonary artery catheter pressure. So that is when a patient is taking a breath. It goes down. In purple is the brainstem perfusion. And you see brief little resumptions after agonal breathing of PCA blood flow velocity, but not in the MCA. So what happens as a person takes an agonal breath, this central venous pressure goes up, and that makes sense because negative pressure in the body sucks blood flow back to the heart. And then there's a brief resumption of perfusion at the distal part of the brainstem and a little increase in mean arterial pressure. This may be the body's way of saying, I need a bit of blood flow to the respiratory center so I can take another agonal breath. Peter Saffer created the concept of bag mask ventilation and resuscitation. This is our own human body's way of preserving that before we in the medical field have now managed to intervene with intubation and drugs and ECMO. And that's just to show the PCA blood flow velocity changes, but nothing else does. Bed positioning. How do we position people at the bedside? for DCD or for CPR. Increasingly, there's been a move to this concept of head-up CPR. However, I would say maybe it's not such a good idea. On the left part of the screen is the posterior cerebral artery. On the right part of the screen, on the right part of the screen is the anterior cerebral artery blood flow velocity. Watch the video. This is supine. Now we put the bed 30 degrees. And then
Go back down.
back supine. The patient was dead at 30 degrees and then became alive again, supine. Now you might say, well, that's just one case. What does that mean? And you're right, it is one case. Here's another case. In this case, on the right of the screen is middle cerebral artery. On the left part of the screen is the posterior cerebral artery. This is supine. And now 30 degrees. Sorry to give you motion sickness. And then shortly we'll go back to supine. Now. So this makes a big difference for death determination science, for DCD. We probably should standardize the way that we position patients. It actually also refutes this concept of probably head-up CPR. Okay, how about biomarkers? Well, long story short, I showed you a lot of cool data. Well, we have not found any blood tests for the brain. Not yet. So that was a bit disappointing. And then finally, the autopsies. This is actually the most popular part of the whole study, and the reason is I think the patients get, their families get reports. And we're able to bank the tissue, which we can go back to in the future for additional analyses. And sometimes we see things that are not expected. This is a picture of the pons. All that dark stuff is an area of the pons that was really irreversibly injured. Those of you who know this field of medicine can attest that a CT scan doesn't show the brainstem all that well. This didn't actually appear on the CT scan, given this, despite this severity of injury. And sometimes we see things that we totally didn't expect. This is a micrograph of a patient in his 30s who was diagnosed with schizophrenia and tried to commit suicide. And two daughters, 4 and 8. And he was a hockey player growing up. He did not, well, he made his clinical expression was schizophrenia, but he actually had chronic traumatic encephalopathy syndrome. So he had CTE. That actually made a big difference for his family too, because now Manulife will pay out his insurance, his life insurance policy for his girls. So this is a finding of participating in research that is not tied to a p-value or an odds ratio. And lastly, I'm going to leave you with a couple things here. We have heard this concept, I'm sure, of where the patient saw the light or the light flash before their eyes. Well, we see some things as patients pass away. So we're shining ultrasound waves to the middle cerebral artery, but also the posterior cerebral artery, which supplies vision. And we see things like this in blood pressure as mean arterial pressure gives out. There's a sudden burst of activity in the occipital cortex with a resumption of a little bit of blood flow. Not a lot, but a little bit. Maybe there's some glutamate playing a role there. I'm not sure. But we see it in a number of patients, actually, albeit small, but very brief. Sort of resumptions of blood flow. And blood flow can only go there if there's something drawing it there, which is, in this case, likely activity. So in the end, Michael's parents, they were right. When they said they looked into his eyes at that blood pressure and he was gone, they launched a line of research inquiry that in fact confirmed their hypothesis. The picture I showed earlier is an actual picture of Michael's eye. And his mom sent it to me in an email, and she wrote something in the email. And that is, we saw the world through his eyes, and that's how we knew he was gone. Both David and Laura came with us to Toronto to present this initial work at the CBS donation forum as part of CCCF. And there's a lot of people to thank for this, but first and foremost are his parents. David and Laura are both here. And without taking questions, I'm going to invite David up to say a few words.
Thanks. I'm not very good at this, so bear with me. On behalf of myself and my wife, Laura, I just want to thank you for having us here to talk. I wasn't really sure what to say in this. This was an amazing study and has amazing potential. But it does come with a human cost. So I'd like to kind of just talk a little bit about that part of it. I want to tell you a little bit about Michael. He was born July 18th, 1995. He was a very happy child growing up. He had a lot of friends. He was very happy-go-lucky, always laughing and wanting to play. He had a lot of friends. He's very charismatic. He grew, he developed a real love for food. He loved cooking. He loved music, playing the guitar. He's a very talented guitar player. And one of the things that he really loved and really enjoyed was the ability to help other people. He was always ready to lend a hand and give any kind of assistance whenever it was asked for. So I think that he would have been very, very happy to be a part of this. The potential for the help that this study can give to other people is just incredible. And I think Michael would have been really happy knowing that he was a part of that. Laura and I, we're not scientists or doctors or anything like that. I don't pretend to understand everything that's being presented here. But we're just, a couple parents that really miss their child. But knowing that so many people can be helped makes the loss a little bit easier. It makes it a little easier to bear, and we really appreciate all the work that's been done in his name, and knowing that his sacrifice can help so many other people. It really gives us comfort knowing that his memory will provide such a legacy for other people. And we just want to thank MIP and everyone who's involved in the study for that. That makes us a little easier to bear for us. So on behalf of myself and Laura, thank you all so much for all the work you've done. And we really look forward to seeing where this is going to go. Thank you.
We'll just, I'm going to keep David up here for questions because I suspect he'll deflect some of mine. So perhaps we have time for 1 or 2 questions, and then we'll get to the next talk. I'm sorry for the virtual attendees. We don't quite have the abilities to have questions virtually. But for those of you who are sitting here, you can just press the button in front of you to ask a question. Yeah, Matt.
Hey, really appreciate all this work, Mip, and obviously, David and Laura, thank you for what you've done to make this possible. Mip, one question for you. Since you've gone to the more invasive monitoring, what has been the consent rate for families to participate in these studies?
Yeah, good question. So the consent rate, so we've only done 2, I should say 5 invasive cases, 3 a few years ago, but they already had the monitoring in situ. We've only done 2 subsequent cases, and we only started enrolling in March. So it's 2 of 2, so it's 100%. But the core study, for which there's 42 participants, it's actually 71% is the consent rate. The screening is whoever my colleagues let me know who would be a potentially interested patient. The one thing I've been struck by is death means something to everyone. And like, as I said, we've had patients, there's been smudging ceremonies. There's been priests at the bedside. There's been patients who we've consented through a translator. And I think once you explain what the purpose is and studying the brain, there are no barriers or divisions in terms of what people want to or who may or may not be interested. So that was actually, to me, all the physiology is kind of cool, but the most interesting finding is actually the feasibility and the consent rate. Awesome. Okay, well, thank you so much. David and Laura are going to be here, so do accost them. And yeah, thank you again. Sam, if it's okay with you, I'm going to save you for after the break. Is that all right? And we'll move on to Julie Crom. So Dr. Julie Crom's, gosh, she's kind of everything. She's an intensivist. She's a neurologist. She's a stroke physician. She's an epileptologist. She's also the Southern Regional, I never know what's happening in Alberta. Yeah. She's also a donation physician, and but she's really one of Canada's experts in neuroprognostication. So she's going to talk to us about that.
So good morning, everyone, and thank you to the organizers, including MIP, for inviting me. It really is an honor to be here and talk to you guys about something that I'm certainly quite passionate about, which includes post-arrest prognostication, both the pearls and the perils. Right. So you heard most of my disclosures. I've sat on a few committees in Canada that have created position statements regarding the management and prognostication of post-arrest patients. I'm also the new medical director for Give Life Alberta South, the Southern Alberta Organ and Tissue Donation Program, and also work as a SEND physician. And then I do work on a research team that's doing some post-arrest biomarker research that's supported by a small grant. And as you heard, I hold a lot of hats in Alberta, but I do work as a neurointensivist in Calgary, and one of the most common consults that I receive are for post-arrest patients where I'm asked to prognosticate, which by definition means to foretell or predict the prospect of recovery as anticipated from the usual course of disease and distinguishing characteristics of a case. Prognostication is inherent to every single patient encounter that we have. It also is intimately connected and influential on diagnostic and management decisions. But it's important that it becomes even more apparent when patients have a real chance of death or disability, which is so often the case in post-arrest patients. And one of the most important things that people need to be mindful of when they're prognosticating post-arrest patients is the percent risk of death for patients from withdrawal of life-sustaining measures due to a perceived poor prognosis, which can be as high as 90% in post-arrest patients. And this is the highest percentage in all patients with brain injury. And that's not to say that withdrawal of life-sustaining measures is not appropriate in many of these patients. It's to emphasize that decisions relating to withdrawal of life-sustaining measures and potentially subsequent organ and tissue donation must be made based on objective evidence, with providers being mindful of, first, do no harm. And by that I mean we need to balance the self-fulfilling prophecy on one side, where a perceived poor prognosis can result in inappropriate limitations to care or withdrawal of life-sustaining measures. But also on the other side, we need to be mindful of providing false hope to family members, where if we perceive inaccurately that someone's going to have a good outcome, this can actually result in possible patient and family suffering. It's also really important that we ensure the process of prognostication is performed with humility and not influenced by many of the cognitive biases that these patients can fall victim to. So at least 3 of my most favorite are confirmation bias, where physicians look for and interpret evidence to support their prior hypothesis. Anchoring effect can be quite common, where you rely too heavily on just one piece of information, ignoring the rest of information. Or the bandwagon effect, which in this day and age where we have computer charting where you can just cut and paste a note over and over and over again, everyone's experiencing that, where you will see that throughout the entire chart, it'll just say guarded prognosis, guarded prognosis, guarded prognosis from day one moving forward. I cannot emphasize enough as well that it's very important to look beyond the fog. And by that, I mean to assess and exclude all possible confounders that can influence both a patient's exam as well as their functional tests such as EEG or even evoked potentials. And this can include anything from medications, metabolic derangements, cardiorespiratory status, and a whole bunch of other things. Because once confounders are excluded, you never actually know what you're going to see. And as you exclude confounders, it's also important to presume the glass is half full unless you prove it's half empty. These patients do deserve the benefit of the doubt. And that needs to be followed by multimodal and iterative approaches to prognostication, where you take a variety of different examination, neuroimaging, and electrophysiological findings gathered over time to inform your prognostication. There's several guidelines and position papers that exist. The 2 most recent that have been published is the Canadian Position Statement, as well as the Neurocritical Care Society Neuroprognostication Guidelines for post-arrest patients. These guidelines emphasize the timing of neuroprognostication. So there's been several studies that have looked at using a variety of factors that are present early on in a patient's course to predict their outcome, including their age, comorbidities, the type of arrest, whether or not bystander CPR occurred, the no-flow and low-flow time, and a variety of other factors. But all of these have consistently had a false positive rate, where you are incorrectly labeling someone with a poor prognosis when their prognosis is actually in fact good, of greater than 5%. So despite the presence of factors early on in someone's course that we may perceive as poorly prognosticating, some patients can still have a good outcome. And therefore, these guidelines often recommend that definitive neuroprognostication should be delayed by 72 hours post-arrest. The focused neurological exam is a mandatory component of multimodal prognostication in comatose survivors, and it must be performed daily and with proper technique. There's 3 components that deserve our attention today. So the first is absent pupillary light reflex. So if someone has absent pupillary light reflex, that has a false positive rate of predicting a poor prognosis, anywhere between 0 to 32%. That false positive rate does decrease with time, and therefore it's best used beyond 72 hours post-arrest when the false positive rate is 0 to 1. Pupillometry is also a new modality that's coming on the scene, which is a far more quantitative and objective analysis of a patient's pupillary light reflex. The machine essentially takes a picture when you're checking someone's pupillary light reflex, and it spits out a whole bunch of numbers, including what's called the NPI, which is a value created from a proprietary formula that essentially quantifies how reactive and whether or not the pupil is brisk or sluggish. And the largest study to date has shown that if you have an NPI of less than 3 on day 1 to 3, that also has a false positive rate of 0 for predicting a poor outcome. Bilaterally absent corneal reflexes have a false positive rate anywhere from 4 to 10% and a wide confidence interval. This is likely the result of, one, this corneal reflex, or your corneal reflex, is highly influenced by technique. There's some studies that have been published that show a large proportion of people don't check the corneal reflex correctly. And also it's our most sensitive brainstem reflex. If someone's on a little bit of propofol, a little bit of midaz, a little bit of opioids, they may not have a corneal reflex. And that's not a reflection of their brain injury, that's a reflection of the sedation that you have them on. So it's best to use these corneal reflexes, one, beyond 72 hours post-arrest, and also if you can combine them with an absent pupillary light reflex, that is again far more predictive. A lot of the older guidelines often talked about the GCS motor score. I remember when I was in neurology in my training many years ago, learning about the importance of the GCS motor score. That is no longer the case. As you can see, the GCS motor score has a relatively high false positive rate, and therefore it's recommended that's not to be used in prognosticating patients, particularly in isolation. However, the false positive rate does decrease with time. This is likely, again, as the confounders that are often more heavily present in the early period start to fade. And so perhaps in some patients, it may be something that, again, you could use with prognosticating. It's also important that these findings be interpreted and utilized properly. A recent Canadian survey actually showed that greater than 50% of respondents utilize absent pupillary light reflexes, absent corneals, and the GCS motor score to predict a poor prognosis earlier than what guidelines actually recommend. So it is very important for people who are prognosticating these patients to be aware of the evidence and the guidelines. Myoclonus is also something that can be commonly seen in post-arrest patients. It occurs anywhere from 16 to 30% of the time. And probably the most important takeaway about myoclonus is that not all myoclonus is created equal. Yes, 90% of patients will have a poor outcome if they have myoclonus, and those are generally the patients that have the classic historical status myoclonus that's defined as unrelenting generalized myoclonus that occurs for greater than 30 minutes. But there are 10% of patients that still can have myoclonus but a good outcome. And a good example of this is some patients who eventually progress on to have Lance-Adams syndrome. Historically, we used to think that Lance-Adams syndrome occurred months after someone had an arrest, but we're now starting to realize that Lance-Adams syndrome is a form of myoclonus that patients can have post-arrest early on, which can occur despite them regaining consciousness. The tricky thing about myoclonus is the timing, the phenotype, the localization does not actually reliably predict a poor prognosis, but what is helpful is EEG. So if you have patients with myoclonus, obtaining an EEG can be hugely helpful. If you find on that EEG in a patient with myoclonus that there's something called synchronous burst suppression, which we'll talk about in a few other slides, or generalized periodic discharges upon a suppressed background, that is highly predictive of a poor prognosis in these patients, and likely the EEG signature that would have been caught years and years ago when people were diagnosing or defining status myoclonus, but just didn't have EEG to look at the patient's brainwaves at that time. However, if you have someone with myoclonus and there's a continuous background, even if there are central discharges, that can be seen in patients with Lance-Adams syndrome, and again, should give providers pause in using myoclonus to predict a poor prognosis. Again, treating myoclonus is out of scope of this talk, but I will say expert consultation is advised in these situations. Seizures are also common, with an incidence anywhere between 3 to 44%, depending on the study that you look at. The majority of seizures are actually electrographic, or clinical manifestations are often masked by sedation or neuromuscular blockade that's needed for other systemic issues. And so EEG is often required to diagnose these seizures in these patients. And again, similar to myoclonus, not all seizures are uniformly associated with a poor prognosis. Up to 8% of patients can have a good outcome. And so this leaves providers at the bedside asking, well, are the seizures that I'm seeing clinically or on the EEG just an epiphenomenon of a severely injured brain and likely just suggest that this patient has a poor prognosis? Or is this one of the patients who's having seizures that may be causing secondary brain injury, maybe prohibiting this patient's ability to wake up? Some studies actually suggest that certain patients can have a good outcome with aggressive treatment of seizures post-cardiac arrest. And for anyone in the audience that knows the Telstar trial that often is used now by many different EEGers across the country and other people to say we shouldn't be treating seizures in post-arrest patients, I would argue that Telstar cannot be used to conclude that. Telstar only enrolled actually less than 10% of patients with seizures. And the only thing that Telstar taught us is that we shouldn't be treating generalized periodic discharges in patients who are post-arrest. But some patients who have no other predictors of a poor prognosis but are still having seizures can still wake up and do really well with treatment. So again, expert consultation can be really, really helpful in these situations. In terms of the electrophysiological tests that we have to inform prognostication, there's two. There's the EEGs that evaluate brain activity, and then there's somatosensory evoked potentials, which essentially test the integrity of the dorsal column lemniscal pathway, where we just put electrodes along the pathway of the nerve into the brachial plexus, the spinal cord, and up to the brain, and we detect to see if these signals are getting to the brain or not. When it comes to EEG, there's 4 patterns that have been shown to predict a poor prognosis. So the first one is synchronous burst suppression. I've heard cardiologists give talks on prognostication, and this is the best way to describe it if you're not an EEGer. So it's essentially VTAC alternating with asystole. That has a false positive rate of 0% if you see it beyond 24 hours for predicting a poor prognosis. Generalized periodic discharges on a suppressed background are essentially like QRSs occurring on asystole without P waves or T waves. And that also has a false predictive value anywhere from 0 to 1% if it's seen beyond 24 hours of predicting a poor outcome. You then on the bottom of the screen, you have non-synchronous burst suppression, which is like fine VFib alternating with asystole. Which is also predictive of a poor outcome if seen beyond 24 hours. And then you have suppressed backgrounds where essentially it's just asystole, which has a false positive rate again of 0%. The most important thing for the 2 bottom patterns is you must ensure that that patient is not on sedation. I can cause those 2 patterns if I put someone on propofol, midaz, an anesthetic. I can cause those 2 patterns if I make them very hypothermic or if I have someone with profound metabolic derangements. So if you're going to use those bottom 2 patterns, you do need to make sure that there's no confounders. Another thing that's often reported in EEG reports is the absence of EEG reactivity. It's really important to know that judging EEG reactivity is really challenging on an EEG. It's very subjective. And it's also not really uniformly tested, and we don't have great protocols for how it should be tested. And so the absence of EEG reactivity should not be used to conclude someone has a poor prognosis. The presence of EEG activity, as well as a few other EEG patterns, such as a continuous background, normal voltages, or normal organization, may actually be suggestive of a good prognosis. And this is really expanded upon in the NCS guidelines, as opposed to the Canadian guidelines that really just focused on poor prognostication signs. Evoked potentials, just really, really briefly, the thing that we're looking for when we test evoked potentials is we're looking for the absence of what's called an N20 potential. And that's essentially just a sign of nerve activity between your thalamus and your cortex. If your N20s are bilaterally absent, that's predictive of a poor prognosis with a false positive rate anywhere from 2 to 4%. But if they're present, again, it doesn't have good sensitivity to say that that patient is still going to have a good outcome. For neuroimaging, it's also really helpful in these patients, and that's because it aids in the detection and the quantification of cytotoxic edema caused by hypoxic ischemic brain injury. In addition, it can also help identify other diagnoses to explain a patient's exam or the arrest etiology sometimes. Your 2 options are CT head and MRI. For CT head, cytotoxic edema shows up as a reduction in gray matter density. The time point by which patients should show their max amount of cytotoxic edema is going to be around 48 to 72 hours, so that's going to be the ideal time to do the scans if you're using it purely for prognostication. There's a very useful measurement that can be done called the gray-white ratio, where you essentially calculate your Hounsfield unit of different gray structures and compare it to white structures. The gray-white ratio in the literature that correlates with a poor prognosis, it varies anywhere from 0.91 to 1.25 with a mean of 1.15, and that, again, has a false positive rate around 2%. A really important thing, though, about CT to be mindful of is it has very low sensitivity, and by that I mean you can have a lot of patients who have CT scans that look relatively normal, but they still have a profound amount of hypoxic ischemic brain injury, and that's where MR brain becomes really, really helpful. So MR brain has a much higher sensitivity, but that comes at the cost of a higher false positive rate. MR brains show cytotoxic edema as an increase in DWI and flare signal and a dropout on your ADC. It's ideal to do your scans between day 2 to 7. If you do them too early, the cytotoxic edema hasn't had enough time to develop, and if you do them beyond 7 days, a process called pseudonormalization can occur where you might actually miss the actual extent of the hypoxic ischemic brain injury. And it's really important to actually take note of not whether it's present or absent, but actually the volume of hypoxic ischemic brain injury. In the literature, a lot of studies out of the States have quantitative software where they can say, 12% of the brain is affected or 36% of the brain affected, and that corresponds to a poor prognosis. At least in Alberta, we don't have that. And so you kind of have to get used to looking at your own images to judge, well, what's a high burden, what's a moderate burden, what's a low burden, because you can have patients with a small burden who still will wake up and do well. And so therefore, I always caution people to beware of getting lost in translation. I go up to the CICU a lot to see these patients, and I will see a report that just says hypoxemic brain injury is present. Again, through no fault of anyone's own, they'll just conclude, oh, well, it's present, so this patient has a poor prognosis, and you pull up the scan, it's actually a really small burden. And I've had a lot of patients wake up and do fine with, again, just a small burden. So it is really important to either look at the images yourself or go down and visit your friendly radiologist and look at them with them. And lastly, for the last 2 minutes, just biomarkers. So biomarkers are released into the CSF and the blood when the brain or the neurovascular unit is damaged. There's tons of different biomarkers that exist, including neuron-specific enolase, S100 beta, neurofilament light chain, and several others. In a systematic review that was actually conducted by Dr. Sekon, they showed that neurofilament light chain may actually be the most predictive, but the problem with biomarkers is that the commercial assays are limited, the exact thresholds vary, and so at least in the Canadian guidelines, it's recommended against their routine use. And as you're collecting all of this information, it's really, really important to make sure that you utilize a multimodal approach because that's been shown to both decrease your false positive risk of predicting someone has a poor outcome and being wrong, but also increases your sensitivity, whereby if all of these studies that you have done are actually negative and don't show signs that suggest a poor prognosis, there's a higher chance that that patient may actually have a good outcome. And the way the Canadian guidelines recommend going about this is they say if you have 2 or more modalities suggesting a poor prognosis, then you have a very, very low false positive rate of that patient having a poor prognosis, and withdrawal of life-sustaining measures in that circumstance is reasonable. One modality suggestive of a poor prognosis, your false positive rate is still probably around 5% or slightly less. However, again, depending on the level of certainty that families require, you may want to delay your neuroprognostication a few more days just to give them a bit more time to see if the exam improves. And if you have no modalities showing that that patient has a poor prognosis, then their prognosis actually remains unclear. And it's really important that those patients are given more time, because with more time comes more certainty. Studies such as the NORCAS study, as well as another one out of South Korea where withdrawal of life-sustaining measures is not actually culturally accepted, they've shown that late awakening can occur in up to 25% of patients, and it can occur out as far as 30 to 60 days post-arrest. So there are some patients who perhaps we should be waiting a bit longer, not all, but some very specific patients. And so after that whirlwind tour, if there's one thing I hope you guys take away, that's that your opinions not only matter, they change lives. And so post-arrest neuroprognostication must be comprehensive, evidence-based, and precision-guided. Thank you.
Press your buttons for questions. Julia, I have a question for you. Maybe I'll just talk into the mic real quick. You mentioned the volume of abnormal signal on DWI and ADC on MRI. How about the specific location? Like, so for example, if you got a patient with, let's say, bithalamic, bad stuff going on, like how do you factor in like the location?
The location, yeah, good question. I haven't found too many studies that have actually looked specifically at that. In the Canadian guidelines, they do define that a large volume should be consistent with bilateral cortical, but they don't specify lobes, and then bilateral deep structures. In my experience, I've seen patients with all of their deep structures preserved, but horrendous bilateral cortical involvement of all 4 lobes. What would be really interesting, but again, I haven't seen any studies if they actually looked at just quantifying the number of lobes that have been involved. Probably a really easy research study for any trainees in the audience. So yeah, great question. I don't have a good answer for you.
Any other questions? Oh, yeah, just press your button.
I'm curious to understand a little bit more about what you mean by like good versus poor prognosis. And what good is it like ECOG status, quality of life scores, alive?
Yeah, much of the post-stress literature uses either what's called the cerebral performance category, which is graded from 0 to 5, or there's a few studies that also use the modified Rankin score that often comes from the stroke literature. Both of those scores they have a lot of limitations. They're very crude assessments. The CPC score it's generally 1 to 2 is considered a good outcome, and so 2, which would be the greatest amount of disability that someone could have but still have a good outcome, is they're able to return home, they're able to do their own ADLs, but they may not necessarily be able to return fully to work or to school, versus 3 is you're severely disabled, you're reliant on individuals for providing your basic ADLs, and then 4, you're vegetative, 5, you've passed away.
Great, thank you. Awesome. Thank you so much. Next, I'm going to call up Alana LeBlanc. So Alana's, many of you will know her. She's a clinical nurse specialist in the VGH ICU, and she's going to talk to us about, while we're sticking with the theme of sort of the ICU kind of care, a really challenging concept in our unit and all units, which is that of the care for the chronically unwell and the challenges that go along with that.
Excellent.
All right. Thanks, everyone. Thanks for the organizing committee for inviting me to speak today. My name is Alana. I'm a clinical nurse specialist at Vancouver General Hospital here in the ICU and also in the high acuity. And I do want to talk about patient and family-centered care during chronic critical illness, and I'll explain a little bit why I think this is relevant to a resuscitation and organ donation symposium. Thank you to Elder Dennis for the beautiful welcome this morning, and I want to acknowledge that I live just down the road on the traditional unceded territories of the Coast Salish peoples. I have no conflicts to disclose. I have received research funding from VCHRI. Few objectives for the talk. I'm going to talk a little bit, just define chronic critical illness for the group. There's lots of different definitions. Talk about a project that we're working on in VGH ICU here, patient-centered rehabilitation, and talk a bit about patient and family engagement, and then some challenges and opportunities to bring it back to the end-of-life topic. So one of the hallmarks of chronic critical illness is that it can arise after a variety of initial critical illness diagnoses. So people come from all different initial presentations and may end up in the space of chronic critical illness. Exceedingly difficult to figure out who's going to end up there. And so that could include people waiting for transplants, people who've received transplants, and a whole variety of other people as well. This is from a recent scoping review, and it describes the population I'm trying to describe here today, that as technologies improve survival, there's an emerging population of patients who survive the initial insult, but who require prolonged ICU stays and may develop chronic critical symptoms or dependence on life-supporting technologies. Because of the differences or the lack of consensus around defining this patient population, sometimes referred to as chronic critical illness, persistent critical illness, prolonged ICU stay, the estimates of prevalence vary quite widely, as you can see in the blue box here, anywhere from 11% estimate of prevalence to, in some subgroups, up over 30. And mortality estimates sit around, in this scoping review, mortality estimate of in-hospital mortality sat around 27%, and mortality at around 45%, sorry. So that brings me to why I got interested in this topic. And so I'm a nurse. I care for these patients at the bedside. Thank goodness it's not my job to try to prognosticate who's going to end up in this chronic state. But when caring for these patients, we thought we saw an opportunity to improve continuity over the weeks and months, sometimes that they were staying in our unit, to improve interprofessional coordination and try to provide some opportunity for patient involvement as well as family involvement. The patients that we involve in this initiative have been in the ICU at least 7 days. They have a slow wean from mechanical ventilation, or we call it weaning pathway 2. I'm sure in your ICU you have a version of that, mostly tracheostomized. The patients themselves need to be interactive, and so they don't have to be like a RAS of 0 necessarily. They can be a little bit altered, and they can have some delirium, but they need to be able to at least participate in physiotherapy. And so what that means is that this group that I'm talking about with the intervention is actually a subset of chronically critically ill patients, because not everybody would satisfy that criteria. And they often have another level of complexity that's led us to subjectively judge that they might need a little help with the coordination of care. The intervention is a personalized schedule, some patient-derived goals, and some progress monitoring, and a couple of other things in the background. This is kind of what it looks like. This is a recovery-focused huddle. It looks like rounds, but it's actually got a few different people in it. And the specific focus of the conversation here is, what is the short and medium-term goals for this patient? Where have they come from? And we're trying to share with this person what we're seeing in their recovery and set up a schedule so they can sort of predict what's going to happen to them day to day, whether that be breathing trials in the morning, physio in the afternoon, these kinds of simple things. And we involve families as much as possible in this as well. And then this is a Chelsea Critical Care Physical Assessment. It's a radar chart that the physiotherapist will score once a week. So we actually have a bit of a longitudinal measure, which is kind of nice. You want the circle to get bigger. And then this is also an engagement opportunity. This is an image of one of our physiotherapists explaining to the patient their score and what they've improved on and what they can be looking forward to in terms of their hopeful for recovery. We've done an analysis in the first 70 patients that we have worked with. You can see here wide variety of admitting diagnosis. This is really just a cross-section of the patients that we see in VGH ICU. Age, again, fairly standard for what we see in our unit. The group of patients that we work with and also in the scoping reviews tend to skew male. And in our group, we have just over a third female. Many of these patients are frail at baseline. This is an estimated clinical frailty scale, and we try to timestamp it about 2 weeks prior to their initial onset of illness. And you can see that while I said that anybody that's been in the ICU for a week would be considered, you can see that in reality, most people don't get enrolled until about 3 weeks in. So median days to intervention was 24 days. Same with ventilation. In our analysis of the first 70 patients, median length of stay was 57 days, ventilation days 50. Hospital length of stay, median 87 days. Everyone wants to know how many people made it out of the hospital. 16 of our 70 patients died in hospital, that's 24%. There's a small group, 22%, 15 patients were transferred to another acute care hospital, and we're working on tracking down those numbers now, so that estimate might change a little. The majority of patients were discharged to a rehabilitation facility. And interestingly, these numbers are actually quite in line with the scoping review that I quoted earlier. Another interesting thing about this group, I think, is the impact on our system. So this cohort of 70 patients experienced a total of 109 ICU admissions, including 39 readmissions. And 70 patients had the impact of over 4,600 days of ICU and 7,800 days of hospital stay. So relatively small number of patients, exceedingly complex, and have a big impact on the work that we do. There is some work being done, mostly qualitative, smaller studies, often nurse-led in Canada and Scandinavia, looking at the experience of living through chronic critical illness and with patients and families, and also talking to clinicians. And if I could summarize some of these studies, it really is an experience of prolonged uncertainty, weeks and months. Patients have small improvements and deteriorations. The complexity of their case increases over time, which can lead to information gaps. We're starting to lose the story. Sometimes there's distress, sometimes there's mistrust between the families and clinicians, some can be disagreements. And patients themselves sometimes are more interactive, but they can end up feeling overlooked and they sort of experience a dehumanizing aspect of the ICU. So what do we do when we end up in this situation? It's very difficult to know when we're going to end up in this situation, but again, I'm a nurse, so now I'm taking care of this person. I think when we're not sure, I think we need to go back to the patients and the families. This is a model of patient and family engagement. It's one that I like, and it is intended to be ICU specific. And the early qualitative work is telling us that engagement is important to patients, families, and also clinicians. And this brings me back around. Obviously, I've focused most of my work recently on thinking about recovery, but we also know that a significant and unknown portion of our patients will transition to end of life. And so when that does happen, and it's sometimes hard to pinpoint that transition, I think we need to be ready for it. And so what are the unique challenges for end-of-life care in chronic critical illness, where that experience of prolonged uncertainty can lead to sometimes some communication breakdowns, and patients or families may have heard numerous times that they're not expected to survive, and it's hard for them to understand we might actually have gotten there this time. Those care continuities breakdowns tend to accumulate over time. There may be discordant expectations, mistrust. There can be perceptions of non-beneficial care or futile care. And when patients do die, there can be staff grief and unresolved feelings. It's a challenging time for everyone. And then there's some unique opportunities. Well, we have time. We have time to develop relationships. We sometimes have the opportunity for direct patient involvement. We can do information exchange and focus on that to learn about the person as a person and focus on humanizing their trajectory of care. We have the opportunity maybe to coordinate amongst the interprofessional team. And I put learning from excellence there because, again, some of that early qualitative work is starting to see that patients and families and clinicians report really instances of really excellent care. So that's engaging, that's compassionate, that's humanizing. But the perception, unfortunately, is that from all clinicians, patients, and families report that that care, that exceptional care, it feels exceptional as opposed to routine. And so I think we have an opportunity as a group. There's already things we're doing really well, and I think we want to inquire deeply as to what we're doing, what's meaningful, and how we can make that easier for all of the clinicians who are sometimes feeling like they're engaging and being compassionate in spite of the challenges of our system. And I think we can keep working on that. A great example of that is things like the 3 Wishes Project. And so in chronic critical illness, those established relationships can help support us to transitioning to end-of-life care. Here's a couple of examples from our own unit. I definitely recommend a personalized end-of-life approach, whether that's 3 Wishes or something similar. And this also has the benefit in enabling compassion at the unit level for the clinicians as well as for the patients and the families. I have a ton of people that are working and supporting this work, and so I'm deeply grateful to be working with these folks and for working with the patients and families. And welcome any questions.
Questions from the audience?
Hi, I'm Lisa. I work at BC Children's in the pediatric intensive care, and I think I really appreciate this work that you are doing there, and because I do think there's parallels in the pediatric setting in critical care, and so I think some of the things you've identified in terms of the tensions that can develop when you have chronic illness in a acute intensive care setting. How do you manage that, and how do you provide that child and family-centered care in our case? So really important work, and I think we can maybe sort of learn some things and maybe look to sort of apply some of those in our setting here. So thanks very much for sharing.
Thanks.
This is really great work. Thinking back to my experiences in these patients is so often they don't know that they're getting better. because it takes so long. You know, the acute phase is, and so having some way of providing feedback that you're building in there to try to keep saying, like, we'll let you know if you're not getting better, but until now, this is what you've done. And look how far you've come. But so great work. Thank you.
Well, I have a question for you. Sometimes these patients, when they've been there for a long time, like they almost become part of the ICU family. Like everybody becomes sort of attached to them. My question is, how do you, when things don't work well or work out, you know, like after they've had a long stay and, you know, it's clear they're progressing to palliative care, how do you look after the staff?
Yeah, I think that's a challenge we're still negotiating. I think I'll flip the script a little bit on you in that I don't think that excellence in care is dependent on the outcome. I think that particularly when patients have been in the ICU a long time, you know, we can be proud of the work that we do when it meets the needs of the patients. And even though we can't fulfill their hopes, if their hope is to survive, we want to be able to transition to end of life gracefully. And if we can do that when we're working with patients and families very directly, it helps to provide a little bit of solace. However, I think there is more that we could do to address those needs and try to provide transparent and open supports for the clinicians specifically. And I know that that's a challenge in our unit and a challenge in many units. And I think there's work that we can do there.
Thanks, Alana. One of the struggles we have in pediatric critical care in this patient cohort is the perception that critical care practitioners are acute care docs and they're really not well suited for the chronic phase of care. Would you agree with that? And do we need to restructure our training or, yeah.
Thanks, Sam, for asking a question to a nurse about how to restructure critical care physician training. I think it's a great question. I think that the difficulty in this population, in the adult, which is my experience, is the uncertainty piece. So there are certainly patients who would transition to a long-term chronic group of patients. And when you look at the literature around chronic critical illness in adults, there's a transition that's poorly defined from an acute care patient who's continuing to have those dynamic changes, which I think is probably very much in the skill set of, from my perspective, intensive and a critical care team. But then there's, patients who may transition to being dependent on they're essentially single system. They may be just dependent on a specific life supporting technology, and there may be some work there to bring in another kind of possibly rehabilitation focused long-term outcomes. I think that there's some work that can be done there. And certainly I think there's some work in the US around long-term acute care hospitals. I don't know where that falls. I don't have a lot of experience with that. That's my non-answer to your question.
Thank you. Thank you so much. I think the response to that question could be summarized as Alana taking the high road. Okay, I'm gonna invite up Ron Chu. Ron's the educator in the St. Paul's Intensive Care Unit, and he's going to provide insights into culturally sensitive aspects of end-of-life care in intensive care.
Sorry, give me a sec. I keep losing them. Yes. I don't think it's presentation. Sorry, we're just getting it out. You have any videos?
No, there's not very many.
Good.
I'm not going to perform Barbie.
Okay, yeah, good.
Are you sure?
He'll put a PowerPoint on it.
Oh, thank you.
Yeah, that's good. So just go ahead.
Try the clicker.
Okay.
Okay.
So the clicker should run.
Okay, that's good.
All good.
Thank you. And hi, everyone. I'm Ron, a critical care nurse from St. Paul's Hospital in Vancouver. Changing gears a bit from the heavy graphs and numbers to more words and about my qualitative research with my team that we've been doing for the last few years. Bringing you back to 2021, height of COVID, our group was discussing our new initiative, the Wishing Well Project, which, like the Three Wishes Project from Hamilton and, of course, in VGH as well, we work to carry out final wishes for patients in ICU. I had this nagging concern, though, which I shared with my team. Knowing my parents, they definitely would not use a wishing well. And when I asked myself why, I think the only answer is that that's just their culture. Well, our project aims to know, can we do better? Adding a bit of context here for our study, we know that Canada is increasingly culturally diverse. In the Greater Vancouver region, over 50% of the population identifies as visible minority. Culture, as we know, influences many parts of end-of-life care. And there's limited studies on culture and end-of-life in critical care. And even within the limited studies, most are Euro-Canadian centric, and the participants are healthcare personnel. And some of the key themes that arise from these studies are regarding usually their barriers to culturally inclusive care and communication. So for our qualitative interpretive designs description study, we invited family members to participate. They've received a semi-structured interview on their loved ones' end-of-life experience at our critical care units. We asked questions about their cultures and how it influenced their experience with their loved ones' end-of-life care. We leveraged our patient family partners for their diverse lens in building our interview guide and recruitment letters. We conducted 11 interviews and identified themes. What we set of wanting to know are these two questions. How do patients and patients' families' culture contribute or influence their experiences of end of life in the critical care settings? And what are recommendations for improving culturally sensitive and inclusive end of life care? In reality, though, the interviews gave us a lot more. For one thing, it's very hard to ask questions about how culture informed people. And how it informed people's thoughts and decisions. The picture on the right is what our astute patient partner described. It's like asking a fish about water. It's not easy to pull themselves out to give answers, since that is the world they live in. Secondly, as we interviewed, we noticed that more and more, critical care itself is a distinct culture. One participant shared, I thought what they meant, turn off the machines. They turned off the machines. I didn't realize they extubated. So that one thought caught me off guard, I have to say. I couldn't figure out why that guy was just standing there the whole time, waiting. I was like, what are we doing? What are we waiting for? But then I realized afterwards that he had to take the tube out. And I was like, oh. Although extubation is something we in the ICU have seen so many times, is familiar to us, this ritual has probably never been experienced by families. So it's important for us to walk them through their process that often are foreign to them. It's also not enough to have experience with healthcare system to overcome systemic barriers. One example was a family member and their loved ones who have had multiple encounters with the healthcare system, but had felt stigmatized due to their history of drug use. This led to communication breakdown, as the family members said that to this day, they still did not understand how their partner ended up in critical care. We also found that culture was definitely not a monolith. It did not just mean certain lifestyle choices, or if you were Jewish or Jehovah's Witness. No participant was just one thing. When talking about culture, family members did not give definite answers. They spoke about their history, their beliefs about life and death, their communities, and their lives at home. Lastly, I A recurring theme is how vivid some of the memories of our participants are. One participant shared how memorable they were when their partner arrived. Again, these are COVID days, so think restrictions. And how grateful they were when the nurse took their time to prepare the partner for what they're about to see. This is an excerpt from an Indigenous and Catholic parent and a residential school survivor. The whole 2 weeks was just, we felt very well cared for. We felt respected. At one point, I said, I need a rosary. I forgot my rosary at home. And so they brought in, I think, a Catholic priest that's there, and they provided me with a rosary. So that was something I needed. That was provided for me. And as I said, the First Nations people were there for me, and all the nurses on the unit were very respectful for me. She's talking about the patient's aunt, used healing stones. We had stones brought in, like crystals. She had different stones around the patient, and we put the stones by his body parts, the different energies. She looked up to that part, and I think she used the bark essential oils. She had a whole platter of them. Like, I don't know how many different oils she had. One night, the time was coming. She said, I'm gonna come in. She ordered these oils from a specific place in the States, and she was frantic that they come before we unplug the patient. She said, I'm gonna try these oils. And she said, I'm waiting for them. They're coming in the mail, and please just wait till I get these oils. So that was one reason why the family, why we were holding off on unplugging the patient. And St. Paul's, the cardiac unit, was understanding, and we understood that the beds filled up all the time there. These are the key takeaways from our studies. We need to be mindful that this is foreign waters for our patients and their family. And even if they have healthcare knowledge, it doesn't equate to being equipped with how to deal with end-of-life situations with their own loved ones. Orienting them to even the most basic or simple things will help reassure patients and families and ease their experience. The more we share our knowledge on what's happening with their loved ones, the more that the family members can understand and hopefully have closure. Nobody is one thing. So to be culturally safe and inclusive, we can't be formulaic. We invite our bedside staff to continue to be curious and be intentional in making that space and time. Ask questions and give time for understanding. And we see this in our wishing well conversations as well. It's often through giving time and space do we get to hear things such as last wishes, rituals, or cultural norms. We have to invite them to bring their cultural practices into the space. And just going back to my mom with more thought about this, I think she would never know that she would be allowed to bring an acupuncturist or a Chinese herbal medicine into our ICU. I think it would take a very curious and intentional effort for one of our staff to make her feel safe enough to ask about it. The small things can make a huge difference. And now one of our team member, Kim, had a recent experience where she offered water to an Asian family. They declined. Upon talking a bit more, she found out that their belief is not to drink cold liquids, especially when they're sick. So Kim, being Kim, boiled some water and offered that to them, and they're very grateful. My own nursing interpretation of why that theme came up is that, like, titrating infusions, fence settings, that's important, but not relatable. But the smaller acts of active listening and kindness are often the ones that stick with the family members and create the lifelong kind of vivid memory, positive memories that take with them. Oh. Thank you so much.
Questions from the audience?
Anna.
Thanks, Ron. This was incredible. I'm curious, has the work that you've done in this study, has it changed how you and your team approach wishing well conversations in your unit or interventions?
I'll talk about me first. It really changed a lot for me personally in how I approach, and just giving that time and knowing that it takes a bit of time for these kind of all their wishes to come out. Like previously when we were asking about it, we were like waiting for a reply, but usually it takes a day or two. They'll come back, give them like what they want, they'll discuss with their family. And in terms of like the unit, some of this research has kind of made its way into our guidelines that we were writing about end-of-life care in ICU. So, hoping to translate that knowledge to the entire unit and critical care in general.
Yeah, thank you so much for this work, and Alana, and really highlighting the importance of family and patient engagement, and more importantly, how to do that in a culturally sensitive way. I guess when I reflect upon a very busy clinical unit and very sick patients, we often are not even good at telling patients that their families that their patients are in the unit. So we're very time limited in our ability to connect with patients. How do you do this work? How do you practically find the time or ability to actually implement some of this very important work?
Yeah, that's a good question. I think especially if during that very critical time, things are very time sensitive, and it will be hard to create that space and time for them. But I think this work has informed me that, like, at the end, when the prognosis are poor, that what really is value based for the family member should be the things that are taking our time. That will stick with them for a long time afterwards. So knowing that has really informed my practice.
Thanks for the talk. The anecdote about extending the time to extubation really was noteworthy for me. I'm just wondering how receptive has like access and flow and management been in those types of conversations or those asks for those decisions?
I don't think I've brought it to access and flow. So maybe we should keep that a secret.
I just wanted to comment, thanks so much. And it's what it brings forward to me is the importance of like interdisciplinary communication on the team, and just like to your point, like how do we make the time for this work? I would say that like this work happens and everyone on the unit might not know about it, right? So it's like it happens on a night shift between like a bedside RN and the family, and that message or that conversation might not reach the people the next day that are going into the family meeting. And so I think it really just it's so important that we're on the team, on the healthcare team, just really being curious with each other, like, and seeking out those people that might know the family the most, or like have had these conversations, so that we can integrate it into like our practice.
Yeah. Thank you for that. That's very interesting.
Thank you. So, David, please.
Sorry, I'm just curious. Have you found that there's been like a shift from more of a clinical information as in relation to the family? Have you found there's been a shift from relaying clinical information as opposed to or more to trying to comfort the family, and if so, what kind of steps have been made to facilitate the transition?
I think personally for me that has shifted, knowing when reading all these interviews and listening to the conversations that have been had. I think the piece about the shift overall in the unit, we're still working on translating that knowledge so that everyone can kind of, I guess, share in what I feel, which is how this piece is really the value in this piece of nursing.
We'll cap it there. Thank you so much. All right. Well, amazing first session. We initially had a half an hour for a coffee break. We're running a tad bit late, but I think the questions were just, and the discussion is absolutely fantastic, and so much of the richness of that we all benefit from. So wanted to let it go on a little bit longer. We'll take a 15-minute coffee break. I'll put in a plug. There are door prizes. In order to get them, you have to go talk to people in the exhibitor hall. But so yeah, let's connect back at 10 to 11, and we'll start with Sam. Okay, if everyone, if you all grab your seats, we'll get started. Okay, I'll just get your attention. Okay, thank you everyone. So this is going to be round 2. And I'm not going to introduce Sam because, I already did. And so we're going to get straight into it. So this session is going to be about talking about what is death, the importance of the brain in diagnosing death and characterizing death, and why the heart is not important. And then we'll delve into predicting when death is going to occur. So, Sam, take it away.
Thanks, Mip, and apologies for all that. I'm just going to skip ahead to where we left off, which is what Sam Shemy and Barbie have in common. I'm going to try that again. Oh, man. Where's our guy? No?
Do you want to press the audio? I can hear it. It's just really quiet.
Yeah.
That's max. And then your volume on your laptop's max. Yeah, we don't need that.
Yeah. So,
listen super quiet.
All right, we're going to skip that one. Let's hope the next one works. Basically, it's life is wonderful. It's so happy. It's so happy. Do you ever think like dying and the music settles down and everything stops? So if you've ever been at a party with people like Mip and Sunny and other people who focus on death or the dying process, it's a good way to douse any kind of positive vibe at a party. But the focus on death sometimes feels a little kind of weird. But then, there's been new research. Whatever you say about our southern neighbors and how they haven't been neighborly recently, you have to give them credit where credit is due. Because death is the nation's top killer. Informed by this very pertinent retrospective work conducted by the U.S. Health Services Organization. So focusing on death does certainly have relevance in terms of its inevitability. And the question has always been and continues to be, is it the heart or is it the brain? In our country, in all provinces except Manitoba, PEI, and Nova Scotia, who have brain-based definition of death in law, the rest of the country, death must be determined in accordance with accepted medical practice. And who is responsible for developing accepted medical practice? It's the medical community. And we've had previous foundations in this country, starting in 2006 with the Neurological Determination of Death Forum, and then DCD Forum, both of which were held here in Vancouver, actually. I have very fond memories of that. And then the pediatric DCD led by Matt Weiss in 2017 that were the foundation for previous accepted medical practice. because of the variability and inconsistency of brain death practices around the world, we, David Greer and I, led this project called the World Brain Death Project, basically to really assist countries who either were having trouble or variability in practices or understanding. It was a comprehensive kind of all things related to brain death, endorsed by 5 world federations: neurology, neurosurgery, neurocritical care, adult and pediatric ICU, and 27 international organizations. We didn't adopt this in Canada directly for the following reasons. It was, while the strengths were, it was broad and unprecedented in terms of how comprehensive it was, leading international experts, high impact publications, and broad endorsement, it wasn't funded, and we had a very inconsistent approach to literature reviews and no formal grading of evidence. That doesn't work in Canada anymore, where the methodology for clinical practice guideline development has to be much more rigorous. There were no patient partners. There was no formal legal ethics representation. Central decision-making to the steering committee focused solely on brain death, not cardiac. No implementation plan, and for those reasons wasn't endorsed by the Canadian Critical Care Society. If you look at the almost mythological status the heart has in our hearts and minds, if I can say it like that, when you look at media portrayals of death, it's all about an isoelectric electrocardiogram, kind of the beep. If you look at the heart and you look at the kind of, as I said, mythological place it has in our psyche, and you look at all the terms we use that are based on the heart: bleeding heart, light heart, open heart, sweet heart, heartbroken, heartache, heartwarming, heart of gold. He's got a big heart, strong heart. People think these are heart words, but it's a common misperception. They're not heart words, they're brain words. And they're brain words because your brain is connected to your heart through neurological innervation or nerves and that we manipulate every day in the ICU, the parasympathetic and sympathetic nervous system, the neurogenic innervation of the heart to the brain. And we manipulate the system all the time. We either block it or enhance it with drugs that use it. But everything you feel in your chest, when you're happy, anxious, sad, psyched, depressed, that is not in your chest. That is in your brain, being felt in your chest through the neural connections for that. And I learned this very strikingly with this guy, Robbie Thompson, who's from Vancouver Islands, who was a kid with dilated cardiomyopathy, had 2 heart transplants. I skied with him at the Whistler meeting that Zena kind of organized, the Whistler Critical Care meeting, and I was nervous skiing with him for the first time, skiing with a kid who's had 2 heart transplants. The first run, we went down, and he fell 12 times. And I'm thinking, geez, it's not a good heart transplant. And I said, Robbie, maybe we should just give it, let's forget about it. Maybe we should stop. He goes, no, I just need time to get my heart rate up. And what he was saying was, because his heart is disconnected from his brain, because they took out his old heart that was connected, put in a new denervated heart, no connections to the brain. His brain can't get his heart psyched up to do exercise. He has to rely on the adrenal medulla and release of catecholamines through there to get his heart rate up. So he can't get psyched up quickly. It takes him time to be able to have his heart respond to the stress of exercise. There is this term that we use, scared to death. It's a real term where people with abrupt, sudden fear actually can die from a sudden cardiac arrest. That is brain-mediated stress with massive catecholamine overload to the heart through the nerves that causes acute heart failure or cardiac arrest. You cannot scare somebody with a heart transplant to death because they're disconnected. So if you're going to sneak up behind somebody and go, boo, don't do it to people who don't have a heart transplant. Do it to people who have had a heart transplant. You're safe. You're not going to kill them. The 2 concepts of death, and we're going to discuss this a little bit, and this is the issue of flow, perfusion, and function. The arrest of the brain is based on no function. That can be in the presence or absence of flow, in the presence or absence of perfusion. But what we care about is the function of the brain. And after circulatory arrest, there's no flow, there's no perfusion, and there's no function. And what we know is the basic biology of life is that oxygen and nutrient delivery is the basic biology of life. Mip talked about it in his talk. Think about it as this is how we deliver fuel to the body and their cells in order to function. And if they don't get fuel, glucose, oxygen, to create energy, they cannot function. And so if oxygenated circulation stops to the body or an individual organ and does not resume within a finite period of time, that body or organ will never function again. And the two concepts are heart-based death and brain-based death. This was a 17-year-old girl with myocarditis, fulminant myocarditis in our ICU, who was on veno arterial ECMO, heart-lung machine, replacing a failed heart. Initially, she had weak heart that was working, and while she was on veno arterial ECMO, I got called urgently to the bedside because she was asystolic, and the resident said she's dead because the heart's not working. And then it was the first time I kind of faced with it. Now it's a little bit normal. But she had a mean arterial pressure of 74, which is like having an arterial pressure of 100 over 60. And so the question is, okay, what makes her alive if she has complete and irreversible arrest of heart function? And that is, you're not dead if you have a machine that can provide oxygenated circulation. And what makes this person still alive, how do we decide to continue the machine, is based on whether her brain function is still working or not, based on delivery of blood that has oxygen to the brain for fuel and function. I was influenced early in my career by this. My chief in critical care in Toronto, Jeff Barker, put this on my desk when I was interested in this stuff. This was the Law Reform Commission in Canada in 1979. Quite a long time ago, before we were talking about all this. They saw what was coming in terms of the impact of life-sustaining technologies, how it interrupts the way people die in the traditional sense. And what they said was, a person is dead when an irreversible cessation of all that person's brain function has occurred. The cessation of brain functions can be determined by the prolonged absence of cardiac and respiratory function. And when the determination of absent cardiorespiratory functions is made impossible by the use of artificial support, we didn't have ECMO back then, it was just a mechanical ventilator, the cessation of brain functions may be determined by any means recognized by the ordinary standards of current medical practice. They advocated the federal government adopt a single brain-based definition of death in 1979. It went nowhere, because they had no implementation plan or no traction. It's really hard to get federal law changed. This was our first attempt at merging the two concepts as heart and brain into a single concept of brain. We worked with the WHO, and Laura Hornby was a big part of this work. And it set the concepts for it, but it didn't proceed any further than this because of geopolitical interference with the WHO. But regardless of what primary disease you have, doesn't matter in terms of the pathway to death, it is the same pathway. Either your brain stops working, and if your brain stops working, you stop breathing and you stop protecting your airway, or your breathing stops and therefore you become low oxygen, hypoxemic, or your heart stops and the arrest of circulation stops. And it doesn't matter what your primary disease is, it all funnels into this pathway in terms of life-threatening illness. This is a helpful concept for trainees in critical care to understand what they're doing in principle in terms of, okay, it's brain, breathing, heart, everything funnels into that, and that's what we do in terms of ICU care to stop that from happening. So when somebody has a life-threatening illness that is life-threatening and therefore will go down this pathway, what we do is we interrupt that with interventions such as life support technologies that we use, and all those interventions are increasingly complicated over time, ranging from an artificial airway and mechanical ventilation, ranging from hemodynamic support, cardiopulmonary resuscitation, ECMO with oxygenators and pumps, and ventricular assist devices or some form of mechanical circulatory assist. And we implement those things, no matter what the disease is, at the front end to interrupt the pathway to death. And we interrupt it based on a presumption. And the presumption is that the life-threatening state will get better with either time, just wait it out. Treatment, surgical, medical, remove the blood, treat with antibiotics, or transplant. And we assume at the front end that this is reversible with time, treatment, or transplant, but it's a presumption that we really don't know at the front end. We need more time to understand how that goes. And as Julie had mentioned, hypoxic ischemic brain injury after resuscitated cardiac arrest is the most common etiology leading to devastating brain injury, death, and deceased donation. And what I love about this conference is you called it an organ donation and resuscitation symposium. And you'll learn a lot during the dying process that can help us take care of aggressively resuscitating patients successfully. But the problem with CPR is that people think that it's all about cardiopulmonary. And in its origin, somebody mentioned Peter Safer before. Peter Safer is effectively the father of CPR and the father of critical care. He established the first modern-day ICU in Baltimore in 1958. And what he called it, he didn't call it CPR, he called it cardiopulmonary cerebral resuscitation. And if we're just focusing on the cardiopulmonary system and we're not targeting cerebral resuscitation, we conceptually are behind what is reality of our practice, which is all our targets of resuscitation should be based on get the heart and lungs going, but get them going in order to reanimate the brain. And it's interesting because resuscitation means resumption of vital functions. The French use the term réanimation cardio-respiratoire or reanimation. Reanimation means I am animated. It's a brain-based word. And that's the word that he used in his chapter on cardiopulmonary cerebral resuscitation, that it's about reanimating the person, meaning reanimating brain function with your interventions. But then what happens when neither time nor treatment nor transplantation can reverse the underlying cause? And that is you've got all these life-sustaining treatments that interrupts the natural pathway to death. This is why withdrawal and withholding of some form of life support is the most common event that precedes death worldwide. And you remove those things and you allow the natural course to death to occur. Well, what's the relationship between circulation and brain? And this is really what MIP and Jordan and other people are really working on. So if you have a sudden cardiac arrest, meaning you go from normal flow to abrupt no flow, a VFib cardiac arrest, you lose consciousness 4 to 21 seconds after your heart stops beating. Your EEG goes isoelectric 10 to 30 seconds after your heart stops beating. So, and that's with an abrupt from full flow to no flow. And this is the only video I've seen in popular culture that actually physiologically portrays this reality. Tell me if it works.
This stethoscope doesn't work. Sounds all right to me.
So that's basically your heart stops beating. It takes 10 to 30 seconds for you to lose consciousness. It's the most physiologically accurate video I've seen in this regard. It's very different, as Mip had pointed out, in terms of if your cardiac arrest is preceded by progressively lower oxygen saturation and blood pressure. You mean you're not going from full flow to no flow, you're going from gradual deteriorating flow and oxygenation. And that is a very different situation, and I'm not going to go through it very much because we're going to hear more about it. But basically, sudden cardiac arrest, your brain stops after your heart stops. Gradual cardiac arrest, your brain stops before your heart stops. And that's a very important concept in terms of withdrawal of life support and the way people die in the ICU. And what David and Laura had mentioned as they looked in their eyes of their son, they saw he was gone. His brain stopped before his heart stopped. This has led us to kind of this work that was a partnership between Canadian Blood Services, the Critical Care Society, and the Canadian Medical Association, funded by Health Canada, in terms of a brain-based definition of death and its criteria after arrest of circulation and brain function in Canada. And the deliverables were a brain-based definition of death, clinical practice guidelines, legal and ethical considerations, stakeholder engagement, and communicating with families. It's been widely endorsed in this country, and this is the fundamental difference from previous iterations of defining death in our country. Death is defined as the permanent cessation of brain function, characterized by absence of any form of consciousness, brainstem reflexes, including the ability to breathe independently, and can result from primary devastating brain injury or secondary to your heart stop beating, no circulation to the brain, no blood flow. This was published in Canadian Journal of Anesthesia April 2 years ago with 28 supporting manuscripts. I'm not going to go into the details of it, but if you want a single place where it's everything brain death, this is a really good place to be. And as I said, there's a lot of humanistic, legal, ethical, family-related support within that publication. And I'm going to show you the video that we created as we thought it was going to be a public educational video, but it's also a professional education video.
The brain keeps us alive by acting as the command center of the human body. It lets us think, feel, move, breathe, and interact with the world. The brain needs to send signals to the lungs to breathe and collect oxygen. Blood carries oxygen to the whole body. Oxygen fuels all parts of the body and brain. Death occurs when brain function ends. There are 3 ways this can happen. First, the brain may have a serious injury and shut down. The injured brain may swell, so blood with oxygen cannot flow into the brain. Second, the heart may stop beating. If the heart doesn't pump blood to the brain, then the brain doesn't get oxygen. Third, the lungs may stop breathing. If the lungs don't collect oxygen, the heart stops beating. Then the heart cannot send blood with oxygen to the brain. In all 3 cases, the brain tissue dies without oxygen. This is permanent. Doctors can use machines to keep the heart and lungs working after death, but they cannot restart brain function. Because the brain keeps us alive, the end of brain function is death.
The end of brain function is death. So technology, organ support, organ replacement has profoundly changed our understanding of life and death. We can support or replace all vital organs except for the brain. We do nothing to support or replace brain function during critical illness. And death is fundamentally a biological process based on the permanent cessation of brain function, again, after a primary brain injury or after a circulatory arrest. Which means that any resumption of brain blood flow after circulatory arrest invalidates the determination of death, and this is where things get a little bit complicated. Bob Trugg has been at Harvard, has been very influential in terms of calling things out. The price and our illusions and myths about the dead donor rule. The transplantation community has twisted themselves into pretzels, creating ethical justifications for increasingly contrived ways to extract organs from people deemed to be dead. It's a pretty sobering comment, you know. The reality is that transplant innovation has forced us to continually reflect and adjust to the realities of the things that we can do in critical care, in bridging technologies, in bridge to transplant technologies, and transplant technologies that have influenced the way we continue to advance and understand this area. But there are truths about this, twisting ourselves into pretzels. There are scientific advances that inform and complicate things. People lack understanding. Adhering to the dead donor rule, it is a medical and moral rule of practice. It can become convoluted. There's consented DCD donors who don't die in time, 30% of them that families have a second hit disappointment if they cannot donate. And there's post-mortem interventions after death that restart circulation and can restart the heart that challenge existing concepts. And if you look at controlled DCDD, there is the pre-mortem phase, which means dependence on life-sustaining treatment and a decision to stop with families, the option of donation consent, the actions of withdrawal, how do you do it, the tempo, the drugs you give for palliation. Do you give pre-mortem heparin? Do you do pre-mortem cannulation, yes or no? And then you've got the peri-mortem with the onset of circulatory arrest based on Sonny's work. You have to wait 5 minutes because that's the time period in which the circulation will not resume spontaneously and it's safe. And then after that, you have organ procurement or post-mortem, and now we have a life support treatment that we use to save life in patients, ECMO, that we are using after death to save organs in patients, so-called normothermic regional perfusion. And what that is basically restarting a extracorporeal, outside the body, heart and lung system that circulates blood, oxygenates blood outside the body. Well, how can you do that to somebody who has just died from a cardiac arrest? And how can they still be dead? They can only still be dead if you prevent any reperfusion of the brain. And the way you do that is with a surgical intervention that prevents reperfusion while circulation is restarted to the thorax and the abdomen and the heart restarts in the body. When you first hear about normothermic regional perfusion, there's a high ick factor. You go, oh, that seems a little kind of contrived and kind of convoluted and stuff. As you kind of go through it over time, your brain adjusts to it, and I'm going to go through some fundamentals here. You have to make sure there's no resumption of blood flow to the brain because all death is based on the absence of brain function, and we use the absence of brain function. We can't measure it, so we have a surrogate that's as reliable, which is the absence of any blood flow to the brain. And as long as you prevent that, you're okay. And the way to prevent that, and I know we're going to get into details further, is you've got to drain the brain. Basically, divert any potential collateral blood flow to the brain by diverting it back down and sink. And this was a UK-Canadian proposal that we came up with at a pub in Hammersmith at a UK NHB. Don't underestimate the value of going out with colleagues for drinks because you come up with a lot of creative stuff. And this is one of the most important papers in normothermic regional perfusion. The idea of draining the brain, and it's not practiced uniformly across the world. And these are the two views we're getting in the literature. One is NRP is great. It increases organ graft functions, increases organ utilization in DCD. It prevents liver injury, biliary tract injury, etc. Versus, we got to be careful. This is ethically concerning. We have to make sure, and we're going to have more of a discussion tomorrow. The number of NRP articles being published has exploded. And this is the logic model that we came up with our Canadian program that's been adapted for any province, country in the world who wants to pursue NRP. This is what we feel are the principles. One is if death in DCD is defined as the permanent cessation of brain function. Australia can't do NRP because their death is defined as the permanent cessation of circulation, so you can't restart circulation after death and call somebody dead. The act of occluding the aorta with a balloon or a cross clamp or dividing and venting the arch vessels after death before starting NRP is medically and ethically acceptable. And the absence of brain reperfusion as a surrogate of brain function can be assured. Then restarting circulation after death does not invalidate the definition in DCD. Restarting the heart and other organs does not invalidate, and it's permissible. This is what we said in our Canadian guidelines. The permanent cessation of brain circulation must be maintained should any post-mortem organ donation interventions be deployed. And Chris Watson in the UK and I are just this editorial's in press summarizing the current state of evaluations of brain blood flow with NRP in the literature. There's not a lot of experience. There's 3 studies, and 9 of them in thoracoabdominal NRP and 23 of them in abdominal NRP that have not shown any brain reperfusion. These studies are ongoing MIPS program and Murat's program in London are looking at this in a deliberate, reflective, and analytical way. And I've shown this before, and this is Michael Chausse's conceptual understanding. What we care about is brain function. In order to have brain function, you have to have flow. That flow has to perfuse the brain, and then the brain has to function. It's similar to a flower pot. The flow is there water in the hose? The perfusion is there water in the soil? In the soil, or in the, what's it called? In the what? Stem. Function is the flower alive? We measure no flow. What we care about is function. You can have some flow, you can have some perfusion, and then how much is necessary for function? That's the key disconnect of what we do. We are focused on no flow, but we care about no function, but we can't measure no function, so we rely on no flow. It applies to ancillary testing and brain death. It applies to normothermic regional perfusion. And so MIPS program of invasive and non-invasive multimodal neuromonitoring, you saw how complicated it is, how large the setup is, but we are really excited in Canada because our work has really sprouted true objective scientific investigation in this area that will help answer these questions, meaning how much flow is enough flow to generate brain function and what threshold below of flow causes the arrest of brain function. And then the Newport study in London, led by Murat Slesarav and Tennille Gofton and Charles Vare, are looking at the same things, the relationship between an arresting circulation and arresting brain function. And this is really what it's about. I think I'm trying to make this as simple as possible. Brain function on the y-axis and brain oxygen delivery on the x-axis. That is the fuel delivery system for cellular function. It's how much oxygen is in the blood and how much blood flow is going to the brain. And as that increases, brain function increases. But there's a threshold below which that cerebral oxygen delivery cannot sustain brain function. That threshold will depend on the person, the type of pre-existing brain injury, whether you're looking at the anterior middle cerebral circulation or the posterior circulation, as Mick pointed out before. It'll vary a lot, but in principle, we want to know the level of flow that's related to brain function. If the function is not there, you're dead, meaning inadequate flow to generate function. And if the function is there, you're alive. The reality of what MIP and Murat and everybody is doing now is, yes, it's focused on informing deceased donation practices, because you could never do this type of research outside of this setting, because how timely. Yeah. You're going to run there with your TCD. But the other thing it will inform is, rather than us just targeting, did we get a blood pressure back when we're resuscitating? Is the patient still in shock? That stuff's important but insufficient. We want to target all our interventions to resuscitating and reanimating brain function, and everything we're learning during the dying process will help inform that. And with time, inevitably, all that technology that's large and unwieldy will become smaller and smaller and more portable and portable, so that we will be focusing on the brain in all our critical care interventions. So I'll just end here. I asked someone at the beginning of life, my 18-month-old granddaughter Emma, and someone at the end of life, my 95-year-old aunt Liliane. So how do you feel about this complex, slippery, contrived line between life and death? So in her defense, she's trying to say frog. And I asked my aunt the same question. What do you think of this? You like it?
I hate it. Not like it. Not only dislike it, but I hate it.
And she's not commenting on this. She's commenting on this pubic hair that was that was growing on my chin at the time. So thank you very much.
Take questions from the audience. Sam, I must admit, I did see you try to grab something here on a few occasions, so you're clearly missing it. Questions from the audience?
Sunny.
Oh, I might. Oh, sorry. They got me first, I guess.
Laura. Oh.
Sorry.
Go ahead, Laura.
So Sam, always an amazing talk. So this has exploded in the last 10 to 15 years, and the science is incredible, and it's been building and building. I just wanted you to talk about, since you're a pediatric intensivist, what do you see about the importance and feasibility of collecting some of this evidence, physiology in pediatric patients? It's all primarily adult focused, and so I just wanted to know your idea about that.
I think that, I've been doing pediatric ICU for 30 years, and and the mechanism of cardiac arrest in children is a little bit different because it's usually primary respiratory leading to secondary cardiac. I know, Sonny knows, Matt knows that if we have an out-of-hospital cardiac arrest in a child who arrives to the emergency room asystolic, no heartbeat, but gets return of circulation, that is death or vegetative survival, and it's miserable. And increasingly, we are seeing conflict about, but you saved their life because their heart and lungs are working, but like the brain is devastated, but it doesn't matter because the heart and lung is the center of life. I think that the transition of our understanding of what the center of life is from the heart to the brain is really important, and it's important to get it out to the public so they understand. And it's important to change the term cardiopulmonary resuscitation. There needs to be cerebral or brain in there to make sure that people understand, because it really is an inevitably bad outcome, and I've seen it, and we've all seen it so many times. And yes, maybe they will die and become donors, but so I'm not going to take an organ donation lens here. I'm going to take a ICU resuscitation lens here. We have to start monitoring the brain the way we monitor the heart, electrically, functionally, and we have continuous cardiac monitors at the bedside that we follow religiously. We need to start getting there with the brain electrically, and please, Julie, develop something that makes EEG interpretation a little simpler. It's like, can you imagine if we needed a cardiologist to interpret a surface electrocardiogram? I got to call you to get... No, we can interpret that in real time. We need to get there with the brain for electrical monitoring and functional monitoring and invasive and non-invasive monitoring, and learning from these programs that are developing. So I'm not sure if I answered your question.
I mean, the research is all in adults.
Yes.
Very little in pediatrics, and I think we've tried a few times to expand to some pediatric centers with more or less success. So I'm just wondering, do you think that's something that's necessary, feasible? Will it happen, or are we just going to rely on?
Here's the difficult reality, and that is that the number of adult intensive care units compared to the number of pediatric intensive care units is, I don't know how many fold higher. The other problem is that proudly, it's not because of us necessarily, because children are resilient. In my unit, we have a 1% mortality. We have 1,000 missions a year, 1% mortality. That's 10 deaths a year. So studying death in pediatrics is going to be a lot more difficult. The adult units have 15 to 20% mortalities. That's substantial. So the ability to study that and process that. But I think there will be a trickle-down effect, and I know that in the UK and here in Canada, we have a separate pediatric focus on things, but doing any prospective study in children is really tough because of the incidence. And so it has to be multi-center, and it has to be feasible and fundable.
Yeah, I got it. Great question, Laura, actually. Sam, had the chance to travel a bit this year, and how do you think, or how important is it to have a worldview on this? Rather, you've really, I think, brought Canadians and the community ICU community, and I think our patient population is starting to understand this from a biologic medical, but so diverse when we go across the world. What's your viewpoint? Do we need to change and convince everybody that this is the way to think about death and dying?
Yeah, it's a good question. There's still countries that struggle with brain death, but I think it is clearly inevitable to me, and it's not my idea. So, Peter Safer talked about it in 1958. The Law Reform Commission in Canada talked about it in 1979. People who saw ahead that it was all about brain. And the biology of brain treatments are expanding. And this, we used to do nothing. We can't change the brain. We're just going to try to support the body, replace breathing, because that's the only thing we can do for brain failure. But the biologic treatments and the interventions are increasing to improve brain-based outcomes. So I think that it's inevitable until you can support the brain, right? Until you can replace the brain, download your consciousness, all this kind of stuff that's, until right now the brain is not supportable and it's not replaceable, but maybe it will be, not in my lifetime.
But it sounds
We have to get that on video, by the way. Yeah, so I don't know. It's so culturally, spiritually, and religiously laden. And the trouble they're having in the States in reevaluating the Uniform Determination of Death Act is that it's so divided and it's led by lawyers. Thankfully, in Canada, it's led by the healthcare profession. And then the lawyers say, yeah, you accepted medical practice, you guys do it, and then that's the law. So it's easier here, and it's easier because we work better together in general as a collaborative society.
Take 2 questions. Dan.
Thanks, Sam. I'm Dan Harvey. I'm an intensivist from the UK, and got an interest in all this stuff. We could talk about it for hours. It's fascinating talk. We've seen the complexity in the diagnosis, both of neurological death and in circulatory, as it's all brain death in the end, as you've correctly highlighted. And we hope that this fascinating research that you're doing in Canada, led by MIP and others we've seen, will lead to some simplicity in the end. But we're getting there via a lot of complexity. And the complexity is there in DBD and DCD. It's increasingly difficult to communicate, not just with the patient, the public, to keep some humanism in all of that, as we've also heard eloquently this morning, but also over to our own colleagues. And we've seen, for example, in the UK, diagnosis of neurological death decrease as the complexity in achieving that diagnosis has gone up, even though admittedly with the safety, we think, and the reliability of that's also increased. So how are we going to bridge that gap? So do you think with our colleagues about actually taking some of this science and turning it into something that they can use to help themselves and help patients every day? Have we got some answers to that?
That's a tough question, Dan. I'm trying to drill down on the fundamental question, though.
For example, we heard about the culturally diverse way in which death might be accepted, and we've heard about the diversity you've got in Canada. That's true around the world. We're going to take all this science, but how are we going to, actually make sure it applies in a justifiable, in a human way to all the different patients and their families we've got in our ICU?
Right. So maybe, I'm not sure if this is the answer, but like the end of brain function is death. The permanent end of brain function is death. In this country, it would help to go back to the Law Reform Commission's recommendation and have a federally legislated brain-based definition of death. If I commit murder, I can't argue out of whether your definition of what murder is. It's the law. And so to me, it is impossible to include religious and spirituality around this. It is really fundamentally, this is what life and death is in this country. We understand it's complex. We understand that I don't understand because the brain doesn't work, but the body works. How does that work? And it's not really the whole body, and we can take organs out and sustain them. We can keep organs living inside the body. It's very complicated. But for me, the permanent end of brain function is the end. And that is, if I can, the way Bob Trug would say it is, that is legally justified futility, right? Because the big problem is calling it death. Like, death means so many things to so many people. Like, is it death of the whole person? Is it death of the person, or death of the body? Is it death of all cells, or is it death of all organs? No, what we mean by death is there are no longer effective treatments. There's no brain function. You're eligible to donate organs. You're eligible to have there's no obligation to continue life or organ somatic supports. And you can donate organs and you can exact your life insurance and burial proceedings. That's what it means. It doesn't mean death of cells, death of organs, death of the body. It means death of the person. And the problem is when people talk about death and debate, it means different things to everybody. And the cultural, where is the guy who gave the culturally, that was a good talk. Everybody has their own internal concepts of what they mean when they use the word death. What we mean is you don't continue life-sustaining somatic support. It is a legal line in the sand. You've lost your personhood. Your brain function is ended. And we have to market that better in many ways.
So just a brief comment. So as probably, I think I'm the only transplant surgeon in the room right now, and therefore a victim of what Bob Trog calls the pretzels. And given everything you just talked about, what's the future of the pretzels? How convoluted do we have to keep being in order to sustain the desire of donors and their families to donate?
So the first future that MIP's going to answer is maybe we don't have to wait for a cardiac arrest. Maybe we have to wait for a certain level of blood pressure and oxygenation in which we have confirmed the brain is not working. So he's going to develop information that's going to inform that. And the debate will be, okay, if it's about blood flow to the brain, he's going to tell us when blood flow to the brain stops and function stops before circulation stops. So it's really a brain, you're converting a DCD model into a brain death model effectively, right? But then the bigger question is, especially in this country where death, the curtain around death has been pulled back a little bit with medical assistance in dying, and I think Matt's going to give a talk tomorrow, that can you donate while you're inevitably dying but not quite dead is going to be the real natural second discussion. I'm not going to be there for that, and I'm not going to take it on, but it is an inevitable consequence of where we're at, and that is, should we be starting to talk about inevitably dying donation instead of dead donation?
That's exactly it. And I think, respectfully, that you will be around for that discussion, whether you like it or not.
Put you as chair.
Awesome. Okay, we'll cap it there. Thank you, Sam. All right. So it's my real pleasure. We had 2 talks left, and then we got plenty of time for lunch. So I'm going to invite up Jordan Bird. So we've talked about death, the concepts of death, brain vulnerability. I'm going to highlight a case, actually. So we had a case on the weekend, a patient who had a DCD. We were intensively monitoring the patient. And my goodness, many of you in the room took your Saturday out to help conduct this case. And unfortunately, the patient timed out. So he kept heart and lungs kept going. And despite every demographic that would have predicted that this patient should pass in time. And so it highlighted the importance of prediction and first of all, can we predict how quick one is going to pass? And if so, how? And so from the concepts that Peter and Sam talked about in terms of the axes of causation, we're going to explore that a little bit further. And so Jordan Bird, I must say, he's not a PhD student. He's probably one of the most talented researchers I've ever encountered. And all the data I showed before was everything that he's done. And so he's going to present on predicting death, part 1, and that is drawing the line of causation from the brain to the heart.
Thank you very much for those words, Mip, and very excited to be with you guys today. So just to reiterate what Sam has just talked about, we know that for donation after circulatory criteria of death, it's pretty simple. We have withdrawal of life-sustaining measures, dying process, death, organ donation. Very simple, right? Maybe NRP afterwards, what could possibly go wrong, right? Except perhaps, we have a dying process that is a little bit too long and then organs become ineligible. And that's exactly what happened this weekend. And so this is a picture from Saturday morning. We're prepping a case. We have approximately 30 individuals. The case involves an older male, cardiac arrest, diffuse brain injury, brain hypoperfusion. It looks like a textbook case that this individual will be a good donor. We have a team for around 11 a.m. in the morning. 30 people are coordinated for this case. And we have a potential organ donation for liver, kidneys, lungs, and potentially a pancreas. And so, we're all very hopeful. Withdrawal of life-sustaining measures. And he passed away the next morning at 6:30, 18 hours later. So it's just how do we have it where it's just we are so sure that we are going to have an organ donation case that we bring all these resources together, and the result is that we have no organ donation, sunk healthcare costs that can be quite expensive, and a second loss for the patient's family, as it's just potentially prepped for it being a short process, and then still there potentially 18 hours later. That's quite tough. And so if you go and look in the literature, there's been a number of attempts to try and predict how long the dying process can take, and these have typically involved things like the neurologic exam, like Dr. Crom was talking about, or respiratory measures. But are those actually the best way to look at predicting death? And so the aim of some of our work was to try and assess the predictive ability of cranial measures versus extracranial measures in order to determine prior to withdrawal of life-sustaining measures to determine the length of the dying process. And we figured, okay, if all the conversation is revolving around it being a brain-centric definition of death, perhaps cranial variables, looking specifically at the brain, might tell us a little bit more about the dying process compared to some other systemic variables or extracranial variables. So in terms of monitoring, what did this consist of? Leaning a little bit on what Mip presented earlier, we had a bunch of cranial methodology to look at both the middle cerebral artery and posterior cerebral artery blood velocities, along with a jugular venous ball oximetry to look at oxygen saturations coming out of the brain. And then for whole body, we had a radial arterial line to go along with cardiac output from a Swan-Ganz catheter and mixed venous saturations and heart rate. And so this process involved, withdrawal of life-sustaining measures through to the dying process and death, where the thing that we really cared about was measuring these variables prior to withdrawal of life-sustaining measures and using it instead to not to monitor the process, but can we predict how long this process is actually going to take? And so diving right into the results, the first thing I want to draw your attention to is this thing called the DCD N score. And so this was brought about brought about in around 2012. And it involves 4 or 5 parameters up at the top. And these are the neurologic exam and an oxygenation index. And this gives a probability that an individual will pass within an hour. And so with that, it's been tried to be validated over the years and not really been super successful. And so one of the first things we wanted to use is just okay, if this is a standard use within the literature, how does our data look? And so most of my data will present with in the same format. So first, we've got on the x-axis the time from withdrawal of life-sustaining measures through to pulseless electrical activity on the x-axis, and then the different variables on the y-axis. And so in this case, the DCD-N score is a score from 0 to 5. And then looking at each of these, we run a correlation to determine is there any type of relationship between these measures and the length of the dying process. Once we have potentially a relationship there, we can then look at what's known as a receiver operator characteristic curve. And so this tells us with what level of sensitivity and specificity we expect someone to potentially pass away within given time limits. And so, for example, here we've got vertical bars for 30 minutes, 1 hour, and 2 hours. And so those are clinically meaningful thresholds for either the literature or liver donation or just timing out of organs. And those correspond to the 3 lines on the right-handed panel. And so with that, the first thing that we see is just the areas under the curve for the potential predictive ability is not good. And so it's just this is one of the more common ones out in the literature, and it's just we're only getting it right 60% of the time or something like that. Crazy enough, 30 to 40% and above of DCD cases time out. And so it's just if our predictive ability is only 60%, that's just frankly not good enough. And so is there potentially better predictors, right? And so next up, we have a couple of cranial predictors. And so the first thing we wanted to look at is extracranial predictors. And so this involved end-tidal carbon dioxide, which is to look at respiratory gas exchange, not predictive really whatsoever. We've got arterial CO2, not predictive. We've got dead space fraction, which is a measure of gas exchange within the lungs. It's a little bit predictive, but not super, super good. And so it's just if you have bad lung function, potentially you're going to pass away fairly quick. And so that's both useful to know for some of our cases, but it's also not very useful for our potential lung donors, where it's just if you actually want to donate lungs and you've got a model that is predicated on bad lung injury, then it's just it's a kind of self-defeating. And so that's not necessarily the best predictor that we might be able to use. Next, we have a PF ratio, which is another measure of lung function and not really predictive. And so it's just from a respiratory variables and gas exchange perspective, does not seem there's much there, at least in this cohort. When we're looking at a couple of other respiratory variables for ventilation, no relationship with respiratory rate, potentially a little bit with tidal volumes, but these are also related to mechanical ventilator settings. And so it's just is this actually a true predictor, or is it somewhat tied to that dead space fraction? And ventilation doesn't seem to be a predictor. And so it's just across the board for all these respiratory data, okay, back to the drawing board. The next thing we wanted to look at was some cardiovascular data. And so it's just as Dr. Shemi was talking about, if we care about respiratory, cardiovascular, and brain, it's just let's look at these exhaustively. Heart rate, not predictive. We look at mean arterial pressure, not predictive. Even cardiac output beforehand, not predictive. And so it's just okay, is there something that we can potentially tease apart here? And the last thing we looked at was a central venous pressure, which is somewhat, can be somewhat used as a measure of intracranial pressure. And so it's just in some ways, this is a measure of the brain. And it's maybe a little bit predictive, and I'll get back to that a little bit later. And so next, looking at some cranial predictors. And so one of the things that we wanted to look at was computed tomography to look at optic nerve sheath diameters. And so what these are is a measure at the back of the eye. And so with that yellow caliper, it tells us exactly what the thickness is, and this can be used as a surrogate of intracranial pressure. In a variety of patients, we do have a little bit of a relationship where individuals that have an elevated optic nerve sheath diameter are the ones that typically are passing away quicker. And so there is some predictive ability with using computed tomography that individuals get routinely before withdrawal of life-sustaining measures. For a couple of other cerebrovascular measures, we also have middle cerebral artery blood velocities, not predictive, and posterior cerebral artery blood velocities, not predictive. Part of the reason why this might be occurring is because we only have velocities, we don't necessarily have flow, and so it's just like, this is only one part of the equation, and that might confound some of these. However, if we look at cerebral perfusion pressures, those are predictive, and so it's just like, going down to around 30 minutes, you've got a fairly high predictive value of 0.83. And so there's some level of perfusion that's getting to the brain that is predictive of how long this process may take. And then finally, SJVO2. And so this is the amount of oxygen that's coming out of the brain. And those individuals that have very high oxygen saturations, potentially the brain is not actually utilizing oxygen. And that may be predictive of the brain starting to shut down. And so might have a shorter dying duration. We also looked at middle cerebral artery pulsatility index, and so this is the difference between the systolic and diastolic peaks on the MCA waveform, as this is also a measure of intracranial pressure. And we found that, again, there was a little bit of a relationship, so it's just really high levels of intracranial pressure potentially relate to the dying process and being predictive. And so at this point, we've had cerebral perfusion pressure, which is partly related to ICP, along with optic nerve sheath diameters, central venous pressures, and this pulsatility index. And so across the board, it's just those four factors, there seems to be some role of intracranial pressure potentially in the dying process. And so those are all physiologic measures, but there's also potentially a way to look at it for that silver bullet or a biomarker that might be very brain specific that we can target, as Mip was talking about in his talk. And so with that, we looked at a variety of neurologic injury biomarkers. And so for these, we looked at four. And so these were GFAP, NFL, tau, and UCHL1. And so the first one we looked at was GFAP, which is a marker of astrocyte injury. And it's not related to the dying process. NFL is also not related to the dying process. However, tau seems to be somewhat related with one outlier. It's a little bit hard to see because of the more lower relationship at the bottom. However, if you go to something like UCHL1, we actually find that in a lot of these cases, if you have a very high UCHL1 value, you pass away quite fast and often under 30 minutes. The interesting part about this, though, is there's actually a point of care device where you can actually measure these biomarkers at the bedside. And so it's if you're thinking about something as an organ donation specialist, and you can go and get a blood sample and actually measure it bedside, along with having a routine computed tomography to look at optic nerve sheath diameters. These are actionable insights that we can get our hands on. They're not something contrived or particularly hard that would take a very specialist ability to be able to get for some of our predictive ability. And so a little bit in summary, there seems to be some extracranial measurements with dead space fraction and tidal volumes that are somewhat related to potentially the mechanical ventilation. And as Mip had talked about, the level of oxygen within the blood can play a role in how soon the brain might cease function. And so that might be the mechanism there. And then some intracranial pressure measurements, and then some neurologic biomarkers of neurologic injury. And so with that, this is a first step to potentially understanding that if we want to predict death, perhaps we do it from a more brain-centric approach so that we have less cases like Saturday, where it's just we mobilize all these resources, really get our hopes up, and then leave absolutely dejected and hurting patient families. Thank you. And this is only possible because of the amazing team that we have across Canada. So thank you very much.
Questions from the audience?
Yeah, that's again great work and good to see. One question: you had a lot of data based on the physiologic outcomes. Did you look at factors related to the support required to get there? So, for example, mean arterial pressure with or without vasopressors is going to be different. Or did you look at amount of physiologic support required?
Absolutely. And so we do have data on hydromorphone, midazolam, and all the different sedation and nothing is related to the dying process. And so it's just like we haven't teased that apart specifically from MAP, but it's just like the pharmacology is not related in these patients. To go along with that as well, we also have a variety of other like blood tests, and so we have like troponin, creatinine, and a variety of other tests, and those also do not relate. And so it's just like for this talk, I kept it fairly brief, but we do have some of those controls.
I should know this, Jordan, but thanks again. Very fascinating work. Did you look at patient-specific factors such as obstruction, that body habitus, because often it's respiratory obstruction that causes that next level hypoxia?
At this point, we haven't quantified obstruction in any of these patients. Personally, without a clinical background, it's just like, I wouldn't know where to start, so I'll defer to Matt for this. But it's just like, it makes a lot of sense potentially to go down that route. It's just how to quantify it beforehand.
Yeah, good question, Huss. I think what we were talking about is like bulbar function. And what's interesting is a lot of the data points towards ICP, and downward herniation and brainstem compression and bulbar function. This whole concept of like we can make the person obstruct, right? Like you can't make someone obstruct. Like it is brainstem down to upper airway, so there's got to be some bulbar dysfunction, and it seems that intracranial pressure-derived metrics keep coming out. Sorry, Peter.
I was just gonna, your comment about neck diameter. Right? We all know that patients with bit of brainstem dysfunction, the skinny necked ones fly, the fat necked ones don't. In terms of clinical, right? Like, and so I do wonder if you were to do something simple as circumferential diameter of the neck on the CTA as a marker of that, or subcutaneous fat depth, at a depth from hyoid, you might have a signal there.
Jordan, you should do that.
Very much so.
I have stupid ideas too.
Okay, awesome. Okay, thank you so much, Jordan. So we'll go on to the last talk. And so it's my pleasure to introduce Sunny Dinani from Ottawa. He's, many of you will know him very well. He's a professor of pediatrics, critical care physician, lead author of the DPART study published in the New England Journal a few years ago. And more recently has been taking advantage of that rich data set to look at a different way of predicting death, and one that is focused on the heart, specifically heart rate variability, which can be a sign of autonomic dysfunction. So, Sunny.
Thank you. I am keeping you from lunch, and I also really have to pee. So we're going to try to do this very quickly, though I have a confession. I grew up in Vancouver most of my life. I now live in Ottawa, and I've changed. Yeah, they brought me down. I feel corporate, and I feel stifled. And here, I want to just be free. Thank you. Thank you. Thank you. Thank you. A few disclosures. I am a hospital donation physician and paid by Ontario Health as a PICU lead, and have a patent on Donation Advisor, which we'll talk about, but nothing with the company itself. And you can take pictures if you'd like. Just a brief summary, because Jordan did an excellent job of this. DCD has been a success, donation after circulatory determination of death, in Canada. It has been the biggest reason that we have increased the number of donors and increased the number of transplants over the last 10 years. Not all provinces did it at first, but we all got there. And so this is important to us. Even though we're talking about the brain, this is how we determine death for many, many donors. However, it is still an occasional event, and transplant is still uncommon. And it's because of the timing of death. It can be from 1 minute to hours after with the withdrawal of life-sustaining therapies. There's a discussion, and then the act of possibly extubating or stopping pressors or something in between, some slow wean of oxygen. A lot of variability there.
And if you don't die in time, every organ has its own special time. The liver is 30 minutes. The kidneys are about 2 hours, sometimes 3. The lungs, somewhere in between. So often, we assess patients and we don't do DCD at all because we don't think, the royal we, don't think they're going to die in time. Most of the times we still go for it because we really protect and value the consent of a donor. And so we go ahead, even if we think they're not going to be in time. And we know 30 to 50% of time donation doesn't occur. And so that's costly. We have whole teams fly in, 30 people around that patient, and we do it anyways because it's important. There's also the grief to the family who have said yes to withdrawal, and then they've said yes to donation, and both things are unfortunate when we don't have donation. The inability to predict which patients will go for DCD is hard. A quote, I remember thinking about 20 minutes before the 2-hour time frame, thinking, no, don't look at, please let these monitors go silent. She was watching the monitors, almost hoping for death. It didn't make sense. It was like a huge disappointment. I think I probably felt more empty then than the actual decision to go to withdrawal. And so for me, it was huge, probably one of the lowest moments. Imagine she had just been through grief of not saving her partner's life. That's hard. There is lots of evidence that this happens all over the world. In Ontario, it happened 30% of the time. It still happens 30% of the time. We've had lots of attempts to predict, as Jordan said. In fact, it's still working. Andreas Kramer's done a nice study looking at DCD-N again. But we're not using them because none of them are accurate or reliable enough. At a conference like this, Andrew Seeley, my friend, and I were playing tennis. I was wearing a tie. We had just finished the D-part study with Laura and Sam, looking at the physiology of dying, and he was just finishing his work on looking at heart rate variability to assess illness. Our study looked at over 600 patients in 20 sites, including VGH. We looked at, out of those, 72 DCD patients, and what we did is watch them die in the ICU after withdrawal of life-sustaining therapy. We watched what their heart rates did, what their blood pressures did, how they breathed. We were looking to see when things stopped, blood pressure and heart rate and circulation, did they restart? Because as Sam said, we needed a time moment to say someone was dead so that we could go forward with organ donation. So we were looking for the resumption of circulation. These are the things we saw. The top one is blood pressure. The bottom one is heart rate. The blood pressure stops. The heart rate continued actually in this patient. So we saw differences. Probably things in an ICU we'd seen anyways. Look how regular this heart rate is. Interesting, huh? So when we looked at Andrew's data, who's an ICU physician and a thoracic surgeon, he said, actually, there's a potential to look at all this data to see if there's variability and use machine learning, because it's a lot of minutes of data, to see whether there's a signal here, looking at the complexity and variability. And in fact, when you look at variability, fluctuations in our vital signs are actually normal. It happens when we're awake, it happens when we're sleeping. And this is a result maybe of the brain, right? Of the sympathetic and parasympathetic autonomic systems that change heart rates to adjust to our physiologic state. And then if we use dynamics and statistics, we can actually analyze these fluctuations. Now, Andrew and his team had looked at previous work in ICU to look at mortality in general after brain injury, to look at whether they were going to extubate successfully. They even predicted sepsis happening 6 hours before a fever because heart rate became less variable. It made sense to me because as a pediatrician, we saw babies being delivered quickly when they put that ultrasound on and the baby had low heart rates or decreased variability. Maybe some of the parents remember that moment where you heard that fetal heart sound and they said, oh, we've got to deliver this baby. It's the same concept. We'd known about it for a long time. Now, Nathan Scales is our engineer. I get through about 3 of his slides before I lose it. So I'm going to go through 2. This one we get, right? ECG, and the peak is the R. And he could look at the variability between EKG signals, carbon dioxide signals, and blood pressure signals. This is when it gets complicated. He uses statistical measures to kind of create frequency spectrums of a low frequency and a high frequency band. Let's not get lost in this. Let's say he can do it. I've highlighted the key important terms for me, that he created bands of short-term variability and long-term variability. And then he could quantify the difference between sections in one's EKG monitoring that we had hours of. And he could also identify variance. So we took this technology that he had already created and looked at our 600 plus patients. We put almost half of them in the kind of analysis cohort called derivation, and then we validated those numbers to see if there was a signal. Now, there was a lot of artifact, a lot of blips and bumps that he had to take out. And we used heart rate and blood pressure because they were the most reliable, and used AI techniques to try to identify whether there was a signal. And there was. In fact, we could identify 3 groups, one with a high probability of dying within, in this slide, a 2-hour window, a 75%, which was a medium likelihood of rapid death within 2 hours, and a low category. We thought this was going to be helpful. It was independent of all the other things that we just asked about, whether you were gagging or coughing, what the pressors were doing. However, we recognized that we needed to be comprehensive. So we took our data and looked at it, and we had an area under the curve of 0.86. That's probably the highest predictor tool that we've seen to date that said you can predict the likelihood of death within a time period. And we could do this every 5 minutes, before withdrawal of life-sustaining therapies and during life-sustaining therapies. We got some Health Canada funding. And I wanted to tell you that we incorporated not just this physiology, that's the new part, but we didn't want to let go of all the other tools that thought things were helpful, like the neurologic, the physiologic, the respiratory, how we withdrew life-sustaining therapies, the drug dosages, and who those patients were, BMI, etc. Then added the variability science, and then kept what we do now, which is ask the clinician at the bedside. But we didn't just ask the physician, we asked the nurse at the bedside and the RT. And so putting those all together, we were able to create an ensemble model, putting it all together. And you can only do this with smart people like Nathan and Christoph and AI. They're synonymous to me. We can do this now every 15 minutes and then categorize them into low, medium, or high risk of death. And so that's where Donation Advisor came into practice, really to see if we could help the donation system. Here's our team. Most importantly, we have Don and Patty Brinklow and Heather Talbot of family partners who were there from the very beginning. In fact, they worked with us on the initial DPART study. So to carry them along to say this is valuable to their experience was so motivating for us. We just completed a feasibility study where we implemented it in the DCD experience, but we didn't let it impact the decisions made by the organ donation organizations. We didn't want to yet change practice. So we showed the clinicians after the fact. We said, could we go ahead and deliver the tool to the clinicians and then ask them with interviews, implementation science, whether this was useful. We had 34 consented patients and we had 19 interviews. What was most important for us is we were able to generate the data and give a tool 100% of the time. So it's feasible. Our numbers in this small cohort were pretty good, that we had a positive predictive value of almost 100%, almost 1. So we were able to predict whether you're going to die in 30 minutes, 60 minutes, 2 hours, or a little longer, almost every time. This is what the tool looked like, because we had a 12-page tool that then, with feedback, went down to 2. The most important part for this talk was the probability of death, the overall probability at the top, but we also felt people wanted to see the individual workings, the clinical aspects, what the physician thought at the same time, and the variability physiology separately. We also had a second part that looked at the same data, but for the transplant surgeons. So they could see the probability of organs being functional during that withdrawal time. That 2 hours can be different for 2 different patients. The first being good heart rates and blood pressures for 1 hour and 59 minutes, or terrible heart rates and blood pressures for 1 hour and 59 minutes. This tool had monitoring and could be delivered to the physicians and the transplant teams every 5 minutes. So Donation Advisor can be deployed. The usefulness and usability is much better. The predictive scores were excellent, and most of the physicians and practitioners and organ donation organizations found this helpful. I think this is most important, that I think it's for the families and their expectations. It will be very helpful. What you're showing me right here is beautiful. It's easy, it's simple to understand. This has been the problem with all the other previous tools, and especially for the surgeons. I think about the surgeons. Tend to really care about this. That was for you. We haven't done this in practice, a randomized control trial to see if the tool makes things better for everybody versus the standard of care. What do we do with the false negatives when we get it wrong? When we say they're not going to die in time, and they do? Or what happens now is we'll say they'll die in time and they don't. That practice currently exists anyways. And now that it's a tool, we probably have to put it through Health Canada regulation. And the idea of bringing in AI bothers people. And so I think we have to appreciate that and see how change management works. We did get funding from Accelerated Clinical Trials, which is CIHR, to start a interventional RCT in 4 sites. We're very excited to actually put this into practice and compare it to the standard of care. And we're able to add on studies to this. In fact, we're going to add that exciting data you just saw of biomarkers and see if that'll make this tool even better. But in fact, it's about the science, this idea of being able to study this and deliver the information to next year's conference to see the next 30 patients. So a brief run through of how we can use heart rate and blood pressure variability that probably includes a brain cardiac axis to make things more efficient and more effective, but in fact to really improve the patient-centric experience, to make sure that families are better informed. I don't know if it'll change consent rates, but it'll be more transparent. That the moral distress from a stand down is very high for our ICU teams and our coordinators. And I think this is about trust. And so if we can develop trust in the system, I think that's a good reason to do science. So thank you very much for your time. Questions? Look at this. It's a tie transplant. It's a tie transplant.
Yeah, as they say, what is one man's trash is another's treasure. It's also an Armani tie.
Oh, how I've changed. It's not Lululemon, you know?
Questions from the audience?
George. Sunny, thanks for a great talk. Always exciting to hear you, and very exciting work that you presented from the Donation Advisor work. A question for you. it kind of feels like we're pretzeling ourselves again to try and answer this question. Do you think we'd ever get to the point where we just extubate somebody and see how they do with a planned interest in re-intubating them? Because many times, and certainly this weekend, that's probably the one test that we'd like to know, rather than all the other physiological parameters that we kind of looked through in the past to try and predict the future.
Yeah, we've started engaging in this discussion. The elephant in the room, which I'm glad you brought up and was hoping you did, that he didn't plant this, is that, we still have this difference in how we actually withdraw life-sustaining therapies. And part of the dead donor rule is that the act of donation can't hasten or cause death. And so the difference of rapid death and extubating, which is what we found, that if you extubate or you stop pressures right away all at once, people will die faster. But everyone's practice right now is so variable. And to dictate practice for withdrawal life-sustaining therapies isn't yet a science. It's an art, and we all live this. And so to now come from a donation perspective and say, here's the science, this is how you should do it, is going to be difficult and maybe not the right way to move forward. But it does start us engaging this discussion, as donation always has brought our end-of-life discussions and withdrawal practices into view. And so I think we need a broader community discussion on withdrawal of life-sustaining practices and standardizing that in general, and then take the next step of non-therapeutic ventilation, so ventilation or recirculation, just like NRP. It's the same concept for the purposes of donation and those organs' viability, as long as we maintain the dead donor rule. And I think that's probably where I'd stop the answer, but there may be others.
Sam.
Yeah, thanks a lot, Sunny. That's very exciting. I've always struggled with this, and that is clinician predictors. What is it that the clinicians are doing? Presumably they're evaluating the patient. There's a bunch of variables that they weight differently, and they come up with some conclusion. Why can't we do that with measuring physiological variables, I guess? What are they doing differently than the physiology?
So there's some great science. I should add that to the talk, actually, that they say that humans use about 7 to 8 factors max when they make a clinical decision. I think we are probably incorporating those 7 to 8 things. But the part that we're not including is, to George's question, the clinician knows how they're going to do their withdrawal. And I think that's the factor that we're not including in our algorithms. We're including all the other things that one might look at, the pressors, the neurostatus, the CT scan they just looked at. We've probably got those 7 or 8 factors. The one we're missing is how they're going to go forward with the withdrawal practice. So we're pretty close, but that might be the single difference.
We'll take one more question.
I tried to put my...
Yes.
Hi, I'm social work, so I want to clarify that, but I've worked in critical care for 13 years, and I'm going to kind of bring it around full circle back to David and his wife.
Thank you.
And the question being, they looked in his eyes and they said he wasn't there anymore. Is there any room in this science and this medical discussion to bring the parents back in and have them say, I'm okay with proceeding with?
Yeah, lovely. I think that's exactly where we want to go, and that's why I started and ended with that. And thanks for highlighting that at the end of this morning, is that at the end, the idea of trying to figure out best practice and predicting time to death, the end goal is to make sure that patient is treated justly and fairly and with compassion, and the family has that. And I think science builds trust. And this kind of information helps us as clinicians be more transparent to those families. at the current moment, when a family asks, how long is it going to take for me, my child to die? I say, I don't know. And I wish I had a better answer. And that's not just in the donation context. So I think you've hit the money there. That's exactly where we want to go. Thank you.
Oh, Sunny. Much gratitude, Sunny, as a gift for all your efforts. I'd like to present you with. Introduce the next speaker. So a little story about Dr. Raju Heron. So known Raju for a long time. He's a neurointerventionalist. He's a radiologist, but also a neuroradiologist, and he does some of the most wild interventional procedures you'll see, probably more so than anyone in Canada. And a few of us, myself, Hussein, Sunny, we were trying to arrange dinner with him, and we did. Took about 2 months to get it organized. It was on Friday night. It was like at 9 p.m. And classic doctor doesn't communicate, right? I'm talking about me. And then I got a call from him about 9:15. He's like, "Hey, man, where are you?" And I'm like, "What are you talking about?" And he's like, "Oh, I'm here at the steakhouse, and I'm by myself." and I felt bad. I really did. But even despite that, I reached out to him probably like 2 days later. I'm like, "Hey, would you do me a favor and come talk at a conference I'm putting together?" and he's here. So I'm gonna bring him up. It's my distinct pleasure to bring him down and have him talk to you about radiographic diagnosis of brain death, which is focused principally on CT and CT angiogram.
You should be good to go. You can use this as well.
Okay, perfect. Thanks. So now you heard my story of rejection. I've been stood up a lot of times, but never by a bunch of buddies. I blocked them. So it's important for you to understand who the guy is in front of you. I'm the eldest of three. My middle brother's a neurosurgeon. My little brother's a PhD. My parents have no idea what radiology is. None. Okay, none. They have no idea. My kids don't know. My wife doesn't know. All they know is that I wake up and I go to work really early and I come home and I smell drunk. I made that last part up. Most of it is they just have no clue. So here I am trying to teach you about radiology today. So the first thing I wanted to do is just kind of reflect on a small story. And there was a cardiologist by the name of Henry Mazgala from a long time ago. And I had him as a clinical skills instructor in first year. And he always talked about style and substance. Style and substance. And he looked at us as first years and he goes, "None of you have substance, so you better have style." So here I am wearing a tie and a new suit and shoes that I had to match everything with. And I'm going to try to teach you about CTA. So this whole point about this presentation has to do with a working group that fell out of a Canadian guidelines recommendation that came along. And it turned out that this was something that way back when, I think it was in 2008, Sam Shemy had asked me to do a review article on the types of ancillary tests that we could use. And you'll see from the people that are on here, many of the names that you recognize, the concept was, could we in BC come up with something that would be workable within this province? So the first thing we did was an environmental scan. What did the other provinces do? Yes, there was a Canadian guidelines recommendation, but was there something that was specific for the different provinces? As it turned out, there was not. And then the second thing had to do with, could we use something that was a reference material for us? And it turned out, and I'll come back to this, that the UK guidelines on this particular thing are quite mature. So what I'm going to focus on is something that you're going to leave with, and then you'll all be part of our working group, and then we'll ask you to read the studies with us. Don't worry, I'm not going to ask you to do that. But it has to do with how do you do this CT angiogram. And there's just some details I'm going to put out there, and then we'll get to the whole point of this. So the idea here is we're going to do a contrast study. So we need to make sure that we have a decent IV that's able to do a rate of injection that is recommended. So this is going to come back to us in a bit. We then also need to make sure that the person that we're doing it on has a reasonable blood pressure so they can actually pump that contrast around and be able to get the picture in the head the way we need to. And probably the single most important thing that you're going to see here is that there are 3 phases to this study. One is a baseline non-contrast CT, and then we're going to do it again with the dye injected at 20 seconds, and we're going to look again at 60 seconds. The other thing that's really important, and anybody who does research understands that we have core labs where all the information goes back to. We actually have to prescribe how we want it done, the appearance of the pictures, and be able to have them reviewed accordingly by the people we want to. So there's a bunch of technical parameters that you see here that are written down that then get put into the system for that particular scanner to go and do and give us what we need to be able to see. Okay, makes sense. When we do this, the first scan, like I said, is meant to be done without any dye injected. So we're looking for hemorrhage, we're looking for other abnormalities, skull fractures, whatever it might be. The second one has to do with an injection of the contrast that we're going to be administering, and it's done at a prescribed rate, so 3 mils per second. And the density of the contrast, we'll come back to this in a moment, is important because you need to be able to see what you're doing. You need to see where the blood is actually going. And remember, the contrast is really a surrogate for where blood is flowing. So wherever we see the dye making its way is where we know we have perfusible tissue. And we're doing this at 20 seconds. And I'm going to come back to some of these timing things because other accepted ancillary tests come back to this. Their third scan is done at 60 seconds. Okay, so we'll come back to that and we'll talk about how this all is flowing. Quick note, it would make sense then, and this is a provincial thing and it's a radiology thing, and you can see, like if you go to Costco, you're going to be buying bulk. So in radiology, they buy contrast in bulk. Why? Because then you can actually get a better price from the companies. And they'll try to sell you slightly different concentrations, but we can't wander too far away from the recommended guidelines for the type of concentration of the contrast. And just think of it like a light. You either have the dimmer switch on full, in which case it's super bright, or you can have it at 50. So the concentration of the contrast is very important to the appearance of what we see on the scan. When we look at this, the base concentration has to be a certain number. And as it turns out, we have reasonable concentrations. It doesn't really matter. But for the purpose of this particular test, even if we had to go buy a specific small batch, single malt contrast, and keep it on the top shelf and occasionally take it down when this study's got to get done, so be it. That's the way that we would do it. Now, the guidelines. So what is it that this is replacing or trying to help with? Nuclear medicine, as many of you know, and cerebral angiography. Cerebral angiography is really only done in very specialized centers by people with the requisite skill and really not that practical. Plus, it's invasive to boot. Nuclear medicine, as it turns out, is also quite limited in its access in different places, both during the time of day, on the weekends, and also just by center. Virtually every place has a CT scanner. And we're not trying to make this complicated. We're not trying to make it into a perfusion scan. We're not trying to make it bells and whistles scans. We just want you to take the picture the way that we want it to so that the picture can be reviewed. I was just talking that there are systems in place for radiology that are called Nighthawk systems. So our on-call work at 9 p.m. can be read somewhere halfway around the world at 9 a.m. and it becomes their day work. So if we can do that and have the imaging be sent around and reviewed halfway around the world, then this imaging can be reviewed the next day by somebody else. So it doesn't matter where the study gets done. It matters that the study gets reviewed the way it should be done. And that's really important. So now the guidelines. It comes down to basic points, and we'll talk about where the publications and the papers come from. But there is a scoring system. And it turns out there's a 10-point scale and a 4-point scale. And as I mentioned, the UK system has already solved this for themselves, and they came down to one that is a 4-point scale. Okay? And you're probably wondering, what does this all mean? Well, because there's a bit of contention as to which system or scale we should use in BC. Should it be the one that's the 10 or the 4? Now, as we go into this, one of the other basic questions is who should be looking at the scan? And this is not a disrespect to people's skills or abilities. But you can understand that when it comes to this particular question, we want to make sure that the person who is reviewing it has the requisite ability to understand the anatomy, the picture, and the consequences of what they're reviewing. So for all intents and purposes, we ask that they be a fellowship-trained neuroradiologist. It's amazing how in the radiology community that can get people quite upset. The term, I don't know if you can call it grandfather, grandmother, grandparented. I don't know. I'm not quite sure how that one works anymore. But the idea is that there are going to be some people who are going to have a lot of experience and know what they're doing and are probably just as good as a person who's fellowship trained. Now, it reminds me that what's a fellowship? A fellowship is a concentrated period of time where you make mistakes that other people have to fix. Okay? And what's a career? It's an extended period of time where you make mistakes that you have to fix. So at some point, you've kind of figured it out. But does that happen in 6 months or 6 years? I don't know. But it probably should not be you saying you're good enough. It should probably be somebody else saying you're good enough. So it is really important to get this right. And now we get to the scale. Now here's this beautiful table. And if you look at the left side, the 10.1, and you look at the right side, the extreme right, the 4.1, you'll see if we just look at the far right side, there's only 2 places you have to look. That's it. Whereas if you look at the left side one, there's a whole bunch more places you have to look. Now, I don't know about you, but it's a little easier to just look at 2 places rather than 10. And if I was going to go for simple, and they're equal, and they have the same ability to discern what you want to discern, I think I want to go with the simple scale, which is why we are going to be doing it the 4, but we will counter with checking it on the 10 locally, meaning provincially, so we can actually show that the 2 have merit, and we can default to the 4-point scale. When you look at it, this whole thing is complicated, but bottom line here is that there's lots of papers that already show that the validity is already there for the simpler scale. That's all you got to take away from this one. And really, just so that we're clear on how this all works, when your heart pumps and that contrast is being sent all around your body, including going up your neck and into your head, basically, you're trying to pick up the dye in the head. And what is it about brain death that's so unique? When you have raised intracranial pressure greater than the mean arterial pressure, it basically shuts down cerebral blood flow, which means contrast doesn't get into the head. That's what we're looking for. That's what we're evaluating for. Why is the 20 and 60-second thing important? Because the 20-second thing is really the arterial phase of blood coming into the brain. The 60-second is it perfusing through the brain and getting out to the veins. And one of the scoring things is the internal cerebral veins, and if you don't have dye getting into the veins, you are not perfusing your brain. Cerebral angiography basically is an arterial phase study. Nuclear medicine, ironically, is also an arterial phase type study. So the fact that you see dye in the head on this CAT scan, this person does not fulfill the criteria. Doesn't matter if it's the 10-point or the 4. And really what we're looking at here is looking at each of these blood vessels and all those things that we're talking about. But if you look at the far right, you'll see it's a little simpler. It says the ICV, the internal cerebral vein. So we can teach people where to look and what to look for. And when we look at the middle cerebral arteries, we can teach you what to look and what to look for. And we can provide you with templates of what's the good and what's not so good, and you can score this stuff. The criteria can be written down in the long way, but the bottom line here is that the tables and the whole presentation has to do with this understanding that CT angiography as an ancillary test works and can work well, with a few caveats. And the caveats have to do with the fact that if I have a decompressive craniectomy, I do not rely on pressure anymore. I've decompressed you. Likewise, if I have a skull that's totally busted up, I do not have the ability to keep the pressure in. And for kids as well, this is not something that's been worked out for small kids or if you're on ECMO. Language is important, and this slide basically speaks to the fact that legalese matters. You have to be able to state things in a way that allows for it to be articulated so that it does meet the medical legal requirements of what we're trying to do. I've already talked about this as special circumstances, but the main point of this whole presentation was to just have a guy in a suit and a tie stand in front of you telling you he got totally jilted by a bunch of dudes that wouldn't come up and hang out with him at a steak dinner. So it's now on them to take him out, and he's just going to blow them off too. No, it's for me to play nice in the sandbox and to be here and to stand in front of you and to thank you all for this opportunity as the sole radiology guy standing in this room. So thank you very much.
I can confirm there was substance and style. Oh, there's my bald spot again. The difference here was he kept his tie on.
Not at reception.
Yeah. Okay. So questions from the audience. Yeah.
Thank you very much, Raj. That was entertaining and informative. Can you help me with passive filling, or what we might call passive filling? Can you help me understand how you see contrast in the intracranial space that might not lead to any parenchymal flow or venous return?
Sure. So the first thing to take away is that contrast itself, if you compare it to blood, is a little bit heavier. So once you know that, and then you know that this contrast is being pumped from the heart and getting out to the systemic circulation, it's actually wanting to flow out to the peripheral circulation. The only thing that's stopping it from getting into the head is the pressure in the head. So if the pressure is jacked up really high, there's no reason for the blood to want to come up. But the importance has to do with the timing of the study. So if it's at 20 seconds, the arterial phase, we know that you have arterial circulation in the reasonable person who does not have this problem. We can see it. And at 20 seconds, that passive filling that you're explaining doesn't really tend to occur very far in terms of going distal. You may see it quite proximal. And this is probably part of the flaw of this whole way of doing it for the 10-point scale. Because at 60 seconds, you're going to have a bit more dye that just kind of falls downhill and tends to flow a little bit further just because it's a bit denser and it streams a bit more. But that's why the internal cerebral veins are so important. Because as far as brain perfusion is concerned, actual meaningful perfusion, you got to be filling the venous system. And what's probably the most integral in terms of the venous system to fill? The deep part of the brain. That's the internal cerebral veins. So what we're really relying on is saying, when I say MCA right, is 2 points, and internal cerebral veins is 2 points. The MCA, we're not looking for stuff that is really, really proximal. We're looking for what we call M4, M5, way out to the ends. And then the internal cerebral veins are basically the check to show, did you actually perfuse your brain to get blood into the deep venous system?
Just to follow up on that, a lot of times clinically we've had patients receive contrast as part of clinical CTAs done earlier. And at some point they may have increased increased intracranial pressure, reducing blood flow. Is there a situation where some of that contrast can still remain in the venous system and lead to false negative?
False negative, yeah. So the short answer is yes. That with a person with reasonable kidney function, you should be able to clear your circulating contrast within a day. And definitely by 2 days. So the proviso is you have to have good renal function. The alternative would be somebody that actually has dialysis, right? So you can clear it that way too. You cannot then do a study that relies on identifying no contrast versus contrast when there is a system in there that maybe there's still circulating dye 8 hours later, immediately after a CT chest abdo-pelvis that you've done everything on. So the take-home point is that this test is being used only when you need it because of confounding variables. And one of the confounding variables then would include a previous contrast study that you should probably just wait a day or two on.
Thanks very much for an excellent talk. And you make it, thanks for the reference for the UK guidance as well. It makes it sound like we've got it all sorted in the UK. I can reassure you that it's not the case. But,
can somebody please remove him?
One of the challenges is around the timing of when to use ancillary tests as regard to when they might be aligned with a clinical set of tests of the brainstem. What's your own personal view? There's a range of opinion in the UK. We have our own. I won't cloud it with what I think, but I think there are some sound arguments in both directions. And a sort of related question is there concern in Canada around the way in which the CTA is interpreted within the overall decisions for neurointensivists making these decisions?
Well, our main concern right now, I think, is what's happening south of the border more than anything else. But no, I mean,
there's some Americans here.
No, hey, I grew up knowing Fahrenheit for temperature, right? I mean, it's different. But no, I mean, just showing how old I am. But we are not driving this, radiology. This is critical care and transplant that are in the driver's seat for this. So when you look at this, it takes time to have swelling and to be able to then have that pressure go up to the point where it's going to beat out your arterial blood pressure for perfusion. So I do think that it's a very important thing to be able to have a discussion about what is the best timing. I'm not going to say that. That's going to be people like Hussein and Mip and George and others that I know that will say, we need this. Ironically, centers like ours don't need this very much. We have very good access to nuclear medicine. There's going to be other places that will rely on this more, and then you get into this kind of perverse relationship where they don't tend to ask as much or the communication's not as good. So I think if there's one thing to take away, it's really important for us to be able to talk to one another and have a proper discussion. So I do think that it does matter, the timing does matter, but I can tell you when the contrast is going to be confounding variable, right? And maybe when we should wait. I think that's important. But you're going to tell us, and as we all know, you can have a test that doesn't show that the ancillary test has no blood flow, but you repeat it in a day or two and it does. So there's nothing about this that's a one and done either.
Last question at the top there.
I had a question about the concept of having neuroradiologists read the scans. If you have a center, say, where they share the workload in regards to CTAs and you don't know who's reading the scan, how would you approach a situation like that?
Well, these are challenges, right, that have to do with practical, real-world ways that we work. And I think it just has to do with one basic thing, which is respect for what the read is supposed to be meant for. And I mean, I may think I'm a phenomenal guitar player. I can tell you my brothers think I suck, right? So it's not what I think. It's what the place shows. And as I said, if I'm reading 200 a year, 300 a year, and I know what I'm doing, I think that's perfectly fine. But somebody who reads only 1 or 2 or 5 and doesn't read very much neuro is probably not going to be the person who says, yeah, sign me up. So the challenges are always how you roll it out and how you implement it. The thing that I'm saying is that we are not far from one another anymore. The virtual world allows us to be extremely close and to be able to send studies back and forth. And simply picking up a phone or texting your local site is able to give you the support you need. And then the goal would be to get more people able to do this type of work. But much like a paper that needs to be published in the New England Journal of Medicine or Lancet or something else, they rely on expert reads to be able to get what they need across first. And I think that concept to me is very important. For us to roll this out provincially properly, this is meant to be read by people who we trust will give the right answer, because the right answer means that the person is declared no flow when they actually have no flow, right? Or missing it. I hope that answered your question.
Great. Thank you so much.
Okay.
I think that was probably the key, is like the gravity of the diagnosis here, which Raju hit on the head. So I got nervous when he made the comment of south of the border, because I met Woody from Idaho during the break, and it was great. I was like, oh wow, there's Americans here, and there's actually another American here, an American from Kansas who lives in Quebec. It's weird. And so it's my pleasure to introduce Matt Weiss. He's a pediatric intensivist. In true American fashion, he submitted his receipts because we reimbursed the flights and stuff. And I noticed there was about a 25% surcharge on what he was claiming.
It's your tariff.
Yeah. And then he said there wasn't, and then there was, and then there wasn't. But Matt's done some really incredible work, really championing donation in a really emerging field, and that is after medical assistance in dying. And so he's going to talk about that.
Thanks a lot, Mip, and really been enjoying the day. I mean, I think we've had a lot of great conversations. You can see how tight this community is that cares so much about donation in all its forms. So, yeah, there's my title. These are my disclosures. I bolded pediatric there because as a pediatric practitioner clinically, I never come in contact with patients who are considering MAID, of course, only being available to patients 18 and over. And yeah, as Mip said, I am in Quebec City, although we do have some representatives from Montreal. Would like to point out that Quebec City is much better. That's what it looks like, and there's skiing at the Massif. Also, a couple quick definitions for people that might not be as familiar with some of the terms, and what you might see in the literature if you look this up later. But MAID, as we call it in Canada, essentially is equivalent to voluntary euthanasia, as it is often referred to in Europe. Not the same as physician-assisted suicide. If you look at literature from, actually, I am from Kansas City, so down south. But because in the sense that patients who take an oral cocktail, because the time until death is so unpredictable, there are, as far as I know, no one has done has organ recovery in the setting of donation after an oral administration of physician-assisted suicide. And DCD is what we'll be using for donation after circulatory determination of death. These are countries with active donation after MAID programs. Canada was definitely a leader in this field, but Belgium and the Netherlands were kind of 8 or 9 years ahead of us with the first descriptions of their programs. Although programs that have not developed as quickly as what has happened in Canada, in Spain now, and an emerging program out of Australia and New Zealand. Also like to make sure that I acknowledge the vast team that has been working on this. Obviously the whole team at Transplant Quebec, Persanto is here as the medical director of transplantation, was key in this program development, but all of the support staff, the administrative staff, Canadian Blood Services was developing recommendations nationally at the same time as the provinces were getting these programs going. A lot of exchanges with Trillium specifically, we developed at the same time. CDTRP has helped. So yeah, has been a big Canadian push in the development of these programs, and of course the patients. For those who can't read this headline, it translates roughly to "you should have paid more attention in high school." But as we have heard from Jin, we know that donation can be a big deal for donor families. Well, you can imagine if you are the individual who is making the choice, it can be an even bigger deal. And they can directly express their consent and their desire and how much it means for them to have a part of themselves live on after they've chosen to end their lives. So just a quick talk on MAID eligibility. I know we got a lot of critical care practitioners here and professionals. We don't necessarily do a lot of MAID assessment per se. And the biggest key is, well, that's how it's supposed to be. This is not a donation system decision. This is a MAID eligibility decision. Guys like Persanto and I, we have no influence on whether a patient is eligible for MAID. We don't want it, we'll never have it. The evaluation is according to evolving provincial laws and practices, and it must be, at least in Quebec, confirmed by 2 physicians. I think that is standard across Canada to date. And until recently, required a patient to be medically, to be competent or apt up until the moment of administration. That is currently evolving, and as anticipated consent becomes more frequent, and discussions of whether the same rules for anticipated consent for donation after MAID would be applicable for, say, dementia diagnosis versus other diagnoses that lead to, say, continuous pain medication administration, where the patient becomes incompetent because of that. How we deal with that is an area of evolving discussion in Quebec. Also, for those of you who might have never seen it, MAID with donation is essentially a modified DCD, but instead of withdrawal of life-sustaining measures, there's administration of the MAID cocktail. And so you are essentially assured of a rapid death. And we'll talk a little bit about that death determination and how the cocktail might influence the death determination. But you can see that in general, MAID is administered, the death determination happens with the arrest of circulation, 5 minute hands-off period, and then another 5-10 minutes before recovery starts. So there's not a lot out there about transplant outcomes. It's a devolving field. There are more and more reports coming out, but the limited reports do suggest that they are similar to donation after brain death donors, and certainly better than standard DCD donors with super rapid recovery. And that is likely related to the fact that while the patients are chronically ill, they did not have an acute injury, either neurologic or a cardiorespiratory injury that happened and led to an inflammatory cascade right before organ recovery. And so these organs, even though they do go through the ischemia related to the arrest period, they often perform at least as well as donation after brain death. So there were, as we were developing our program, and these are the same things I'm sure that were a lot of the questions that happened here in BC, there were some controversies. One of them was information versus solicitation. We wanted to make sure that there was never any idea that we were selling donation to potential donors, or that to give any kind of impression that their access to MAID services would depend on their agreement to donate, for example. And so there were a lot of discussions around who should discuss the possibility of donation after MAID and when to discuss it. And the current Transplant Quebec position is that MAID providers can and actually should inform the patient. And we talk about MAID providers, that could be the palliative care doc, the family med doc, the internist who is discussing this with their patients, but only after MAID decisions are finalized. And there has been a little bit of back and forth whether there should be after the second formal agreement or whether after the first assessment. After a lot of discussion, we've come to after the first assessment, understanding that the rate of the patient changing their idea between the first and second assessment is effectively zero, as well as we're going to make sure that they have the ability to change their mind, and they're assured of that. And really, when the back and forth with the ethics committees and the people who are MAID providers, we wanted to respect equity and autonomy here. The idea being that when we first started our program, we wanted the only offer to patients who came with the idea that they wanted to be donors. But realistically, what that does is it puts the responsibility on the patient to know that this is a possibility and to ask for it. And if we can assume that donation is a potential benefit for the patient themselves, as Jen would certainly attest to, not to mention our multiple donors who've gone to the media about this, well, if they are effectively excluded from the donation process if they just don't happen to know about it. And exactly how that gets worded, I've often told people to say, once the MAID assessment is done, you can say, well, have you signed your donor card? And the patient might say, well, what do you mean? I could be a donor, my body is, I'm getting made here. And no, there's still a potential, and we can explore it if you like. That is, now some of the other controversies were around death determination. We know that there needs to be an accurate diagnosis of death to respect the dead donor rule prior to donation. And there's a tension between being accurate while having the minimum level of invasive monitoring possible. The 2023 guidelines recommended an arterial line or an ECG as the only routinely accepted methods. And this is something that I get a lot of calls about in centers that they're doing their first MAID. It's often the first donation they've done in their hospitals. We don't transfer MAID patients into organ recovery centers or hospitals. We do it at the local center. And so what we're talking about is the need to have a flat line, art line. Obviously, that's a bit invasive, and it's a big ask for the patients. And so a lot of patients, because it might be technically difficult, they might just not want another stick. They've gone through all kinds of other issues. They might prefer an ECG. It's a lot less invasive. I know here in BC, you routinely administer potassium chloride in the setting of donation after MAID. That is not something we do in Quebec, which is it's a quirk of how the Collège de Médecins de Québec initially wrote the MAID protocol. But it's something that we're certainly working towards, and something I would love to collaborate with you guys about time to death after administration of KCL. The other thing, and Sam alluded to this during his talk, death by donation, and the idea of, these are patients who have chosen to die. Why does the mechanism of their death have to be administration of a MAID cocktail followed by a flatline ECG? Why couldn't the mechanism of their death be general anesthesia followed by removal of vital organs, such as the heart or lungs? Well, first of all, donation after MAID is still currently bound by the dead donor rule in Canada, and death by donation would currently be illegal. So that should be reason enough to talk about it now. Now, I can certainly say there is a reasonable ethical debate to be had around the risks and benefits of death by donation if it was legally permissible. Because I personally don't feel there is a significant difference between, say, death by administration of a medication versus death by removal of a vital organ. But that being said, I think this is a debate that would have to be out to the broad public, and something that we would never want to give the impression that we are changing MAID criteria or MAID processes without having a broad consultation just to facilitate transplantation. And I think you certainly have to think about the risks to trust in the system, something which the whole donation and transplant system relies upon. So those are some of the issues we had in developing the program. If you talk about system outcomes, well, you have to get an idea of the frequency of MAID in general in Quebec. Now, these numbers are specifically not, and I don't know if there's a pointer, but anyway, are specifically not the donors. These are the number of MAID procedures in the province of Quebec. So you can see the first year, 2015, 2016, only 63. That number has skyrocketed to more than 5,500 in the last year available. It's, if you look from 2020 to 2023, there were approximately 75,000 deaths a year, with MAID accounting for 3 to 8% of all deaths in the province now. So it's slightly above the national average, but in most provinces that's roughly in line in the single digits percentage. So a non-insignificant number of MAID procedures going on. And I think this is the paper that got me invited here today, according to MIP. It's something that Prasanto and I worked on. This is a CMAJ report that we had on the first 5 years of donation after MAID in the province. These are just the hard numbers. You can see, a relatively steady rise, obviously interrupted by COVID, and specifically in 20 and 21. But in that 5 year period, we had 64 donors for 182 transplanted organs. The demographics of those donors, you can see the majority were between the ages of 50 and 70. 86% were neurodegenerative disorders. We're talking ALS, Parkinson's would be the most common. And actually the ALS community in Quebec now, if their Facebook page includes, if you're considering MAID, talk to your doctor about the potential of donation. It's something that has really been integrated within that community. But also available for terminal cardiopulmonary disorders. These are just by a chart of the specific organs that were transplanted by year. Obviously, kidneys being the most frequent, not surprising. Livers and lungs, though, a good number of those as well. I think this is when when Prasanto and I started looking at these numbers, this is the thing that I think surprised us the most, is the percentage of our total donation activity. And you can see in 22 it was up to 14% of all of our donors were through the MAID pathway. It has really become a relatively routine part. It's rare when I open up iTransplant these days that I don't see at least one MAID donor being evaluated and worked up. And just the activity since in 23 and 24, roughly in the same ballpark, a slight dip in 23 relative to the total number of donors. But the question is, how does that relate to the potential? What is the potential for this pathway? Obviously it has increased the number of donors, but could it be double that, triple that? It's hard, and how would we know? So, again, Prasanto and I've done some rough estimates. These are back of the envelope calculations. But if you look at, for example, in 22, there were 3,500 MAID cases. If you would assume about 10% eligible, and that's consistent with, if you look at there's the Commission Fin de Vie, so there's a commission in Quebec that looks at the reasons that they were doing the MAID procedures, and about 10% are neurodegenerative disorders. So if you would assume that there would be roughly 350 potential referrals. The vast majority of patients, as I'm sure it is in British Columbia, are metastatic cancers. We do not encourage, of course, referrals for metastatic cancers. But in that time period, we had 109 actual referrals. So we can assume that there were referrals that were not happening. But it makes conversion rates very difficult to estimate. And part of that problem is MAID is not part of mandatory referrals, so we don't audit those. When MAID is discussed in a doctor's clinic, and maybe the patient says no, and then nobody calls Transplant Quebec, fine, but maybe it's just never brought up. And it's almost impossible for us to know whether it was even mentioned or not for a patient who was eligible. So that makes the actual denominator unclear. In the paper, what we did do was we looked at what happened to the referrals that we at least got. And over that 5 year period, there were a total of 245 referrals. Now, about 2/3 of those were excluded right off the bat. And when I say right off the bat, that's the physician is calling us from their clinic. They're saying, hey, I've got this potential donor. Could this patient who is potentially interested? And roughly half of those that were not accepted were for a medical unsuitability. Maybe they had a remote history of skin cancer, something like that. There are all kinds of reasons why you can't become a donor. And that was by far the most common. There was consent not obtained. One thing I didn't mention yet is, as here, for donation after MAID to happen, it has to happen in the hospital. And so pretty quickly, some people drop out because when that is explained that they can't die at home, well, they're not going to be interested in this as a procedure. And then a few other reasons, if they withdraw from MAID in general, deceased before MAID had been administered, et cetera. So of the 82 that were retained, that's how we talked about this, is that we had retained referrals. Well, there was much less attrition at that point. And for the patients that didn't proceed, it was only 22%, and almost all of those were medically unsuitable, with a couple patients that passed away before MAID had happened and before we were able to organize donation. And so the actual donors were 64, and if you look at that, it's about 24%, or about 1 in 4 of our total referrals. But if they make it through the first round, it's almost 80% actually become donors. And that's also not surprising, because once the patients have said, I'm interested, and you've done the initial medical screening, these patients are often very, very motivated to make this happen. There's a lot we need to do to better understand this process, and we need better donation process data. We need national definitions, standard definitions, so that we can compare better between provinces. We need donation rates indexed to total MAID numbers within the province and within the country. And audits that really look at every step. For instance, I had the 20% we didn't obtain consent. Well, why didn't we obtain consent? What were the factors that the families or the individuals didn't like about the process that led them to not give consent? We also need rigorous graft outcome reports. That's something that we're going to be working on soon in collaboration with CBS and CDTRP, to at least within the province of Quebec be able to give some better outcome data. But there are a lot of other research questions. So we need to look at the impact on patients and loved ones. We need to know the true reasons for refusal, like I mentioned, KCL as part of the MAID cocktail. And we need to look at the ethical exploration of emerging issues. So if we were to enforce mandatory referral, is that ethically acceptable? So could we have some way to both count how often the MAID providers are not referring, and have systems that encourage them to do so? Normothermic regional perfusion is going to be the hot topic tomorrow, but should MAID donors be among the first patients where NRP is applied for different forms of NRP? And death by donation, as I mentioned, which is one of the ones that I think is going to get the most discussion over the next few years. For further reference, here are a couple references. This is some of the first cases, a report from 2019. This is, a publication from 2018, but it still, I think, is a great exploration of the ethical and legal issues as we were developing this process. These are the updated guidelines. If you went and got coffee today, you saw this ad from CBS's Her Last Project, which is a fantastic documentary, a physician who herself received MAID and became a donor. And that is it. So merci beaucoup. And there's my email. For the questions.
Questions?
I have a question.
Yeah.
Thanks. Just on your list of ethical issues, I was curious about where the discussions will be or are intersecting with medical assistance in dying for when mental illness is the sole underlying condition. Because I was just thinking about the trust in the system issues, where so many of those, like futility, is determined in part because of the lack of access to treatments. And anyways, I was wondering, is that part of the ethical space and discussion right now?
So absolutely, and I do think that's something that it is an emerging issue that I should have kept on there. I think that the issues are going to be around competency. And what we have stated again and again at Transplant Quebec, and really in the donation system in general, is if a patient is deemed competent enough to make a decision around MAID, then they are surely competent enough to make a decision around donation. Now, we would never pretend to be the experts in evaluation of competency for that MAID decision, and we don't want that responsibility. But we will downstream likely rely on that evaluation of competency to accept donation at that point. So I think that's really where we're not in a rush to implement it. I think what we've done in general is, as the MAID program itself has evolved, generally we've said, okay, we're going to wait a year or two, see how the dust settles, and then try to implement a new, and then see how we can incorporate these new type of donors in. That make sense?
So Matt, great talk as always. This is more of a comment than a question, obviously. And it kind of comes back to the last comment, and that is that when you'll recall that when we started this, we would get the calls for to evaluate every MAID donor. And some of the time, the reasons for requesting a MAID to us seemed eyebrow raising. And we were quickly slapped on our knuckles by the Commission de Soins de Fin de Vie. This is not your wheelhouse, right? The decisions regarding MAID and eligibility and stuff do not belong to the donation and transplant community. That has already happened. We're not involved in that. We're not allowed to be involved in that or comment on that. MAID's been decided on, and if they've agreed as well to organ donation, or they seem to be potentially organ donors, then that's where we get involved and we proceed. But we can't retrospectively go back and challenge anything around the decisions around eligibility for MAID and so forth.
Take one more question. Do you mind if I ask a question?
Yeah, go for it.
So talking about NRP, you'd mentioned MAID and NRP, and I was talking about this with George yesterday, and I think I've spoken to this about Sam, and like, oh geez, that's like the MAID group is the highest risk group. But I'm like, oh no, it's actually not, like because they're getting such large doses, the brain has gone quiescent. So like it seems to me actually even a bit more of a safer group. And I think Prasanto mentioned in Toronto, Prasanto, you said something along the lines of like, and it seemed to me like a brilliant idea actually, like, well, why don't we just give an anesthetic? Just wondering if you can comment on that.
Yeah, I think that, you know, we haven't gotten into the meat of the NRP debate. That'll be more tomorrow. But really the issue is, okay, if somehow whatever drain the brain techniques that you use, whatever clamps fail, and there's reperfusion of the brain, is it riskier in a MAID patient with a presumably uninjured brain versus someone who has gone through some type of brain injury, most likely to be that led them to be in the DCD process, and I think it's an open debate. You know, Murat and I have talked about this. Sam and I have talked about this a little bit. You know, certainly the lack of cerebral edema is going to say that if there is an absence of flow, if your interruption of the cerebral circulation is effective, well, those findings are likely more generalizable. You can say, like, look, it wasn't because there was cerebral edema. I think but there's certainly, you have an uninjured brain, and if the clamps fail, or whatever techniques you use fail, the hypothetical risk of the patient experiencing pain, once maybe that anesthetic or the propofol that was given for the MAID cocktail, is that the risks would be more dramatic as well. But it also, I think the thing to consider is that all of those risks and benefits in the setting of MAID can be explained directly to the patient. Whereas in a standard DCD setting, it's almost always a third party who's trying to give a best estimate of what the best interests are for the patient. Whereas the patient could say, look, I understand, clamps could fail. I might feel something. You'll give me some more anesthetic at that point. I get it. Yeah, do it. You know, that person could give a valid first person consent in a way that I think adds some weight to those patients as potential first NRP patients.
Great. Thank you, Matt. You'll see more of Matt tomorrow at the NRP debate. All right, so it's a real pleasure to introduce you to two individuals. On September 30th, 2024, I had the opportunity to meet Rick Harris. And the study that I showed in the beginning of the day we're doing all this monitoring on the brain and so forth. Mind you, those are all critically ill patients. So experimentally, and for generalizability, to provide a control group or a non-injured brain comparator cohort, we conceptualized the study of doing the same study, but in patients proceeding with MAID. And we've reached the last talk of the day, and we're bringing back Sunny D. Not the orange juice. He is sweet. He's not artificially made. And then after this, I'm going to do a little bit of a wrap up for day one, and then highlight some things. But I'm going to pass it back on to Sunny. He's going to talk about the advances and the future. As my colleague Hussein often uses his hands, the future of organ donation.
Thank you. Thanks for having me, MIP, and a great group of speakers today. I would like to thank you for putting me right before lunch and then right before people want to go home. And right after Mackenzie. It's excellent. It's excellent. I think we've seen a lot of research. What I want to impart to you in the next 25 minutes is to talk about our community of researchers, that this is about Canada and how well we've done when it comes to the science of organ donation. And I'm going to focus on the donation side a little bit rather than the transplant so that we can give ourselves a pat on the back in this room. And I'm also not going to mention everybody because there's a lot. So if I left somebody out, I apologize. We really have gone places. I won't show this again. I'm a hockey player. I say that with quotations. I play a few times a week, beer league, in nets, and I'm terrible. But every time I get out there, I think of Don. Don's my hero. He's actually a patient partner with the research we've been doing. Don was a goalie too, and he was in nets in his Thursday afternoon beer league, and he remembers it. He tells me the story. Player coming down the ice. It's a breakaway. He makes the save, and then he collapses. Collapses on the ice, and he's a very lucky man, though having his heart fail suddenly while he's playing hockey is not that lucky. But he was playing with firemen who quickly realized what had happened, cut his equipment off, and put him right on the ice. He was on ice. This is resuscitation science. They did CPR for 45 minutes, and he got to Kingston General. He eventually needed a transplant, and he got one. He's really thankful. And so when I go play hockey, even if I lose, I'm very thankful. But this affects donors, the donor families, and transplant recipients. We're all in this together. And when I think about the stories, and thankfully, thank you to the three families who spoke today, because it helps me reevaluate why I do this, why we do this. And it's not science for the science of knowledge. It's not because it's really fun to hang out here. Frankly, often I question it's not because Sam told me to do this, as he was my my first mentor. It's about trust. Why did people become donors? Why did Rick do it? Because he trusted the system. And from there, we build standardization in our community. But it's all about trust. So I went to AI and I said, what is trust in donation? This is the only AI slide. And these are the four things they brought up. Social trust, beliefs, values, concerns are represented in policy and practice. Inclusivity, trust in the system, that there's assurance that the system operates fairly. Trust in healthcare providers, that's us, that we're doing the right thing for our patients. And trust in the process. death determination. We talked a lot about that, NRP, that we're doing it right. So when I look at science today, let's look at it in this context. And trust is an issue. This is a story of Takesha McKitty, who died a few years back after a fentanyl overdose in the Toronto region. She fulfilled criteria that we had standardized for brain death, for neurologic determination of death. And they hadn't approached for organ donation or anything. But the family resisted that declaration and, in fact, took it to court. Her heart stopped, I think, 1.5 years later. They kept her on a ventilator while they sorted this out. There were multiple declarations. There was lots of neuroimaging. But there is a difference between what the family felt and what the healthcare team felt. And in fact, it did go to the Supreme Court, which felt that the doctors had the right to fulfill a medical diagnosis of death versus the cultural, spiritual biases needs of the family. But in fact, over that time, the healthcare team, Andrew Healy and his colleagues, got to know this family. And when they talked to this family, they realized that this wasn't about science. This was about trust. I highlight Amanda Van Beinum, who's an anthropologist and socialist. She probably is. Sociology, PhD, working in Ontario, who took on to bring this team together to write this. And the idea is our community can bring together to understand what we're doing. And when we look at the science around donation, I've now reflected, this is what we're doing. Anytime there's a gap in trust, Canadian researchers like Amanda chase this down. This is Amy Sarti, an intensivist from Ontario, who talked to hundreds of families with her team after death and dying experiences in the ICU and donation experiences. And look at the richness of the information. This is just a bit of it, of the stuff that families needed to hear, and we just didn't understand. Use clear and consistent language, anticipate and clarify things, repeat information, provide openings for their end-of-life rituals. We were in our own little bubble. I'm going to go through a lot of these slides, and it's not the details. I want to focus on why we're doing it and who's doing it. Some more studies looking at trust at end-of-life care with families in our ICUs. Samantha Anthony, a social worker out of Sick Kids, pediatrics, who looked at family vetoes. That's when an individual says they want to be a donor, and the family actually overrides that and says, we don't want them to be a donor. That happens 10 to 30% of the time. Why do families do it? Anyone? Trust. Thank you. And now we're talking about research in death and dying. Who thought MIP could do what he does with patients? Well, in fact, these guys, Nick Murphy, who's an ethicist, again, a different class, different genre to round out our scientific experience, says actually research in the dying and the recently deceased is really acceptable. That in fact, people want to participate in this because it builds trust. So take home, diverse community of researchers, and that the family perspectives are the cornerstone of what we do. Trust in the system. I think we can all admit that Canada has a long way to go when we look at diversity and equity. And we're probably farther along than most countries. Even just looking at this room, it is really diverse. Mary Bocage, in memory, was an Indigenous leader and researcher who led this study with Samantha Anthony to look at how pediatric donation occurred and what the needs were of those patients and families. Carolyn Tate, an Indigenous leader and CIHR chair, in research, is looking at the challenges facing Indigenous transplant recipients specifically. And in fact, she's created an international network looking at how organ donation impacts in Australia, the UK, other nations, including Canada. These are leaders here. She's out of the University of Calgary. Murdoch Lees, looking at increased infectious risk in donor status, looking at groups like, I've lost my train of thought, men having sex with men, who weren't allowed to even register to be a donor. He's changing that single-handedly. And you know what's impressive? It's the organizations, like the organ donation organizations, Canadian Blood Services, CDTRP, are following suit. We have leaders, and they have support. So addressing the inequities in the system and not focusing on the numbers of increasing the number of donors or transplant is making this important to individuals. We have trust in the healthcare providers. And in fact, we recognize already that coordinators have a heavy burden when they talk to families. I think Jen explained it very nicely, that what a great example of how important that contact was. But in fact, how hard is that? This is Vanessa Silva, who was a coordinator herself, who is now a PhD researcher in her own right, who recognized that system and the coordinator being in the middle, and then looked at interviews and surveys, and has now put together all that information to create an interventional package to help donor coordinators do their job better. And what I mean better, I mean not to get more consents, but so they can live long and happy lives doing this very hard job. We'll probably talk more about medical assistant dying, but thanks to Matt for giving that preamble. What I want to highlight here from Amina Silva, who's a nursing doctorate. Again, the diversity is not doing this after the fact. She's looking at how MAID is impacting donation and transplant here in Canada in a systematic way, looking at a scoping group, what other countries are doing, surveying families and clinicians, doing interviews, looking at the data, and then prospectively looking at how we're going to do this better. It's a systematic approach to research that builds trust, and that's what's super important here. I'll champion Matt again, Cynthia, Christina, and Stephen Bede out of Nova Scotia. They were the first jurisdiction in North America to look at presumed consent, where every donor doesn't have to check off a card. They're automatically a donor unless then the healthcare system is told otherwise. That's happened in a lot of countries, just like that. And sometimes it hasn't gone well. What's impressive about this team and our system, you could see we had CDTRP, National, Canadian Blood Services, National, Transplant Quebec, Provincial, Nova Scotia Health, Provincial, a whole group of people supporting. In fact, this was a Health Canada initiative, but they looked at the issues before, during, and after. Did this actually make a difference? And no spoiler alert, but it probably didn't make the difference you thought it would be as far as increasing consent. What they're probably finding is that it was the system change of all the education, all the systems that were put in place to allow presumed consent to happen that actually improved donation rates in Nova Scotia. So because of this study, did the rest of the country go to presumed consent? No, not yet. But they did look at this data that shows that a system is important. But the research, what we take home from the last couple of slides, is that methodology is important. That this idea of not implementing change just like that, but planning it, studying it while it's happened, reflecting on it, and then repeating it if necessary. And the national provincial collaboration. And let's focus now on the donation process. I'll end with a couple of slides really looking at the advances in where we're going. When we looked at death determination, and we've talked a lot about that, There was a lot of controversy. There were news reports like this. There was a CBC Fifth Estate episode. Some people in the room might have a bit of PTSD from it. It was hard. That said the medical system didn't know how to determine death. People were becoming organ donors or selected for organ donors before they had the chance to live. It was a blow for trust. And what did we do to fight back? Science. This is the reference paper that came out last year that we've mentioned a lot today. What I want to highlight here is the reason it was different is it wasn't consensus. It wasn't just 100 people in a room across the country saying this is how we want to determine death. It was based on science. There was methodology to that. There was evidence practice to say low certainty, high certainty, that every recommendation in that guideline was based on some sort of work to be based on. That's new, how we define death, the ethical considerations, the legal considerations, and the huge stakeholder involvement. That was what was important here. And that's why you're hearing that these guidelines have built so much trust. Look at the number of organizations that were involved because of trust. Death determination is hard. We've already heard about neuroradiology and ancillary tests. There's so many little factors. This is Mikhail Chasse, who's going to publish one of the biggest papers on ancillary testing and neuroradiology in this forum called CT perfusion. CT perfusion, I can't give it away. Can't give all the answers. But the point is that what we're doing here is systematically answering the questions that drop trust. This is the big paper that Laura helped me with. Sam was the senior author that looked at how people die in the ICU. The top line is the blood pressure, and the bottom line is just green, is the electrocardiogram. And you can see that it's gone flat. I'm going to just repeat it. Oh, it won't go backwards. Oh yeah, hold on. Okay, let's play it again. This was at the moment of this individual's dying. And we remember all those people who consented. It goes flat, there's some artifact, and then it came back. That was the question we were trying to answer because that was destroying trust in our system. Clinicians were saying, are we going against the dead donor rule? Families were looking at this, nurses were looking at it, the coordinators were looking at it, the transplant surgeons were looking at it. In fact, this was hard to start, but when we did start, everyone thought this was a good idea. And the most important number there were 20 sites, 631 patients, 67 actual donors. It's the 93. It was a 93% consent rate from families. Nothing is 93% consent rate. But they believed in this because they trusted the system that we were going to look at it. It also took 13 years of our life. This is what we found. That in fact, the resumption of circulation did occur. It occurred actually 14% of the time. That's like 1 in 8 people dying in an ICU after removal of life-sustaining therapy. But it happened fairly quickly, like within 2 minutes. And it only happened for a minute or two. That's not my time, is it? No, that's somebody else's time. The longest period was 4 minutes and 20 seconds before there was a resumption. And that resumption actually happened just for a blip. The reason that's important is we had the standard of 5 minutes. Okay? Now, we only had 600 patients. We probably need millions to really prove it never went over 5 minutes. But what did we do? Trust. It built trust. Because we said this was important, we hear you, we'll answer it. We didn't need more patients. Will it happen? Possible. But this guides our practice. We also actually answered other things, like a blood pressure is needed because feeling your pulse is not reliable. That in fact, we noticed that the waveforms changed and got scale, they lost scaling. So we had to do that very particularly, which we didn't do. That the ECG was very different from actually circulation. And so we separated that. And that we gave guidelines that if this happened, when this happened, because it happens enough, that you just restart the clock before donation. And those donors previously would have not become donors. They would have stopped the DCD process. And now they still probably can, because everyone has trust. Looking at the science, we weren't the only ones doing this. David Zorko did a systematic review of all the literature looking at resumption of circulation. This is the work that went into those guidelines, that then we got together and made a consensus building. So this is what's really important when we look at science. And this is Canada doing this. This was impressive. We now recognize that it's not just about circulation. What's really important? Up here. Murat's in the audience today, and we heard a lot this morning about its brain arrest. That's probably important. So correlating what happens after circulation stops is super important. Murat was quick to pick that up, get funding, and put EEG, transcranial Doppler, electrophysiology, to see what was happening in the brain. And of course, as he doesn't just look at the science, he looks at the law, the policy, the ethics, because this is what we do in Canada. And in fact, their preliminary findings on pilot studies show exactly what MIP showed this morning, that the brain stops almost a minute and a half before circulation stops. That's reassuring, and in fact will build trust. The next big question is NRP. So we're going to head that tomorrow. But Murat's already on top of that. His team is now looking at what they were doing before with dying patients, now looking at patients undergoing NRP here in Canada. Other countries started it without this science, with the worries of maybe brain being reperfused. Our team said, wait a minute, why don't we study it first? Just like LEADER. Let's plan it, do it, study it, then act. Amazing. He's done 12 patients. Again, I don't know the results of that. And we won't go more into evaluate, but trust in our own team builds trust in the system. And I think if we're answering our own questions, super important. And we talked about Donation Advisor earlier. So I'm going to end with 3 studies that are the next wave. The next wave is about doing intervention in donors. Most of the studies that I've showed you so far are observational. Some of them are qualitative, talking to families. The next phase is actually doing things to potential donors to change outcomes, to make them better donors, and to actually potentially make better organs for better transplants. Synergy, led by Fred Darragon from Sherbrooke, looks at a drug, an immunosuppressive that's used in almost all transplant recipients. And his idea was, why wouldn't we do it in the donor to suppress the immune system of the liver and the kidneys before transplant? But that means giving a drug to a donor, and this drug's not going to help that individual who's dying. It's a whole new level of research. And this drug could potentially reduce kidney failure in those recipients. So this is how he's operating it, that a donation decision occurs. Before allocation, they consent the donor also to this research program. And that donor receives tacrolimus or a placebo. And then the organs are recovered and transplant. You know what's really interesting? That what he found was, yes, you had to get permission from the donor, but in fact, the transplant recipient now had to get consent, not to get an organ, but to have an organ that had been researched on. Whole new area of science that Fred and Maureen now opened up. A whole new area of science about science. What's happened so far? Well, they've had 53% of eligible donors enrolled. That means half of them didn't get enrolled. Why? Because they couldn't get the SDM, that's the substitute decision maker, to be contacted. 5 of them actually declined. There was no research team. 2 physicians actually refused. And I don't know if you can see that or pick up on that, but those reasons are the same reasons people say no to donation. So we have to explore research of why a family might say yes to research in this situation. It might give us insight on why someone might say yes to donation in general. So some really exciting research. On the transplant side, 100% of recipients said they'd take an organ, even if it had new novel studies to it. So it opens up a whole new door of research. Dan Harvey's also in the audience. Dan is also doing a randomized control trial. It's probably going to be the biggest RCT and organ donation in the world. It takes advantage of the UK system of a national referral. It all comes through one center rather than provincial. And they have all the data in one place. And it embeds research right into the practice. That when you go for an organ donation consent, you actually also go for a organ donation research consent. And that's a whole new area where we could learn from. They're also trying a drug that might help function in the recipient, which is simvastatin. And again, it's not about the drug, it's actually the methodology. Their plan is to get 2,600 adult brain dead donors over 4 years to be given simvastatin before organ recovery. Now, they've got 150 sites enrolled, and they've got over 1,300 donors involved. So that's a huge, huge study. And that they've got almost 75% of those get randomized. So we're going to then see the outcomes of simvastatin on these patients. Again, not about simvastatin. It's about the methodology of having the whole system believe in research for donors and for transplant recipients in one fell swoop. The last study I'll tell you is the most recent. I think that's supposed to say decedent, not decadent. We would spell decedent differently, wouldn't we? Yeah. It's a good time to mention this. Yeah, really polished until then, yeah. So decedent means dead. Well, decadent means different. So imagine what they pitched for about $1 million, competing with a lot of different studies, to allow what we were doing in those donors, but then transplanting into those individuals rather than just using drugs. Let me explain. So we have a donor. We remove the organs. They put them on a perfusion machine, which is this kind of standard in practice in Ontario. Perfuse those lungs, give them antibiotics. But before putting them back into a transplant recipient, they're going to put it back into a donor to see if that lung works and to try different immunotherapies in that donor. So in fact, the donor is no longer a giver of organs, it's a giver of the body as a functioning unit to look at the immense immune reactions and drugs to support those lungs. And then in this study, they won't be transplanted into something else, but the goal would be as those lungs function, that they would then be transplanted into somebody else. Amazing. Bold. Think it could never be done. And they got granted. That's what we're doing here. Why? They had patient and families to say, this feels right, this feels okay to us. They had ethicists, they had social workers to say, we can do this, and we all wrote it together. So the last I'll end is the community, and how do we bring research together? Well, we've created a donation physician network under Canadian Blood Services, which is really our national organization that supports a lot of this. I don't know how many times you've seen this logo on all the slides I've shown that support the independent researchers that then support policy and procedures, that support our community. Coordinator Network has almost 250 members. And this is where we share these sort of studies, like behavioral science to understand decision making. How we talk between donors and recipients was last month's talk by Nick Murphy, the ethicist. And Andreas Kramer, the intensivist, looked at prediction of time to death, just like we talked to today. And what it includes, that's my time, is Canadian Critical Care Trials Group, the Canadian Society of Transplant, and I label BC Transplant because that's where we are. But most of these studies have the buy-in from all the organizations, all the donation organizations across the country. It's really an impressive group of people that are working together. The Canadian Donation Transplant Research Program started about 12 years ago. And it was funded by CIHR, and now it's a nonprofit. But really, it brings together investigators, donation and transplant, but most importantly, it brings students and patient and family donors. There's actually over 100 patient family donors that participate in research supported by CDTRP. There's a lot of active projects right now and supports a lot of active funding. And these are the kind of things they do, like the Patient, Family, and Donor Research Forum in June. That's just about patient, family donors that speak to the research they're involved in. That's super important. And thanks for giving me a little bit more time, because when I talk about community, we have to talk about Sam. Now, I look at Sam as a clinician, because he let me into intensive care, maybe with a few choice words of why I wanted to be there. But he's also a thought leader, as you've seen and heard. He's also a mentor to many. He's also a provocateur, maybe decadent at time too. And this, I don't know what happens. Like, but despite that, last year, Sam got the Order of Canada. And I want to take a minute because I don't think we've done this formally, and it's a great moment. As a leader in research for all of us, this is what he's done when we come to community standardization and science. And he's built trust in the system. So thank you, Sam. Okay, I'm going to add, so Sam was a leader of critical care. Is he crying? Nice. Nice. Hold on. Let's do a selfie right now. Okay. Everyone say hi. Okay, thank you. To do this, we've relied on critical care, right? To build trust. We've had patient family donors, even here today. We've got a new research community that's broader than just ICU, social work, nursing, ethics, resuscitation science, transplant. Where we need to go is build the bridge between what we're doing in donation and link it to the great work that's been done in transplant. These aren't twins. This is the two of us, Prasanto and I, at another conference. We wear the same outfits a lot. But the point is, this is how we should be doing it. That bridging the gap to build trust is complicated. AI gets it. but we need time to figure this out. So I want to thank you for your time. I really do appreciate it and happy to answer questions.
Questions for Sunny?
This might be a silly question, but the research project where they're taking the lungs out, testing them and putting them back in the donor, are they going back in the same donor or a different donor?
I think it's likely the same donor. Yeah, but I don't think that's definitely the way, but it's going to be one center, so it's probably the same donor, right? And that's how it'll start probably, right? To maintain perfusion in a brain dead donor is probably possible, and getting consent for it because they've already been a donor to then carry on to do this novel research will be the same donor.
Hey Sean, we should do that study.
Oh, yeah, sure.
I think we all heard that. Yeah.
That was
Yeah.
a strong yes, sure.
Yeah. Yeah. Other questions? I know it's before dinner, but and I took a little bit longer, but thanks so much.
Thanks so much, Sunny.
Thank you.
All right, what a day. So this wraps up day one. A couple things I want to mention. Firstly, we've got door prizes for day one, so we'll do that in a second. But what I do want to mention to the people that are here, even the people who may have left, after this, there's wine and cheese that's included as part of your registration. There's food, a little bit of food available there too. It is 2 blocks from here. It is in the Medical Student Alumni Center. We're going to have chaperones, lead groups there. It's like you're back in kindergarten. For Santo and Sunny, you guys can hold hands. So after this, we're going to lead you there, okay? And it should be a good time. The purpose of this is to enhance what this is meant to do, which is really drive collaboration, those physical collisions of idea generation, thinking outside the box. Us in BC undertaking studies where we take the lungs out, put them back into the donor. Very exciting, Sean. So that's going to happen right after this. There is feedback, so on a QR code here that we'll seek from yourselves on both days. So please do take the opportunity to fill that out. It's really quick. The other thing I do want to mention, again, a little plug for Nurses Week. As a thank you, we've got wine for yourselves, right? So do make it out to that wine and cheese, which will start around 5 o'clock. Or sooner. As soon as we get there, yeah. I think that's it, right, Zena? Oh, next slide. Yes, Nursing Week. I mentioned this, though. Okay. That was it. So Nursing Week. It's important. So we'll see you at the Wine and Cheese, and then tomorrow we're going to delve into in the morning, go straight into normothermic regional perfusion. So we finished today with talking about death and dying, the science of death, to then donation, and tomorrow's going to be post-mortem interventions, and spend the morning talking about normothermic regional perfusion. And then in the afternoon, it's going to be following the gift of life into the recipient. Okay, here comes the door prizes.
We're just going to do 3 today.
Okay, we're doing 3 today.
We're on a time.
All right. Actually, you know what I'm going to do? We've got our 3 patient partners here. So I'm going to go to each of them, and they're going to pick actually, would you mind coming to the front? Mary, Mac, and Jennifer. And we'll pick the door prizes. Yep. So you guys pick one?
Thanks. We have to read them up.
You got to read them out.
Oh, I have to read them up?
Yeah, you got to read them
Somebody
out.
has to read them.
Okay, first door prize.
760056. 760056.
Yay! Okay, come on to the front. All right, Mac, you're up.
Okay, up next. 759688.
Oh, yay!
Yes.
I hope I can read this. 5315-844. 5315-844.
Okay,
Okay.
we'll read it tomorrow.
Oh,
okay.
Or should we do another one?
No, we got to do another one.
Oh, okay.
We got to give this stuff away. Oh, right there.
Wait, we got it.
Oh, okay.
There we go.
Put that one back in there.
Okay, awesome. Thank you. All right. I wasn't sure what it was. I was hoping it wasn't an empty bag, but there's stuff in there, so that's great. Okay, thank you again, and we'll see you at the Wine and Cheese, and then tomorrow morning.